We have Wednesday, March 26th, 3 o'clock, the welcome to the Minnesota Senate Human Services Committee. Then I'm asking, there's a ton. David, we got a list here. It's gigantic. We want to try to get our conversations. So we're asking testifiers that are coming, please, man, get to your point, under 2 minutes. And if you don't do that, I'm going to start telling jokes that'll last forever. I'll make some funny jokes. So my wife is right. I'm not funny, so don't try to be funny. So let's get up. Aaron Maye Quade, you ready to go on 2640 of members? All good with that? 2640, Community First Services and Supports, Reimbursement Rates, Modifications, Provisions, Certain Consumer-Directed Community Sports Budgets, Increasing Provision, Minnesota Caregiver, Defined Contribution Retirement Fund, Trust Establishment Provision, and Appropriation. Did I get that all in one breath? And it gave you enough time to get up to the desk. I think Monica Flavin is here too. Where you at, Monica? Come on down. Come on down. You're the next contestant on Human Services. Senator Maye Quade.
Thank you, Mr. Chair. Thank you for having me in the icebox. I have Senate File 2640 for you here, and I would like to thank my co-author, Senator Abeler. This bill attempts to match the funding language in the governor's proposal. In addition, certain non-union providers will get the same rate increase as programs within the bargaining unit. And while this bill recognizes our current budget challenge, it continues to make necessary improvements in our home care workforce and their elderly and disabled clients who need these services. The new contract agreement will cover over 38,000 workers in 4 home care programs. The programs include PCA Choice, the Community First Services and Support, or CFSS, budget model, the Consumer Directed Community Supports, or CDCS program, and the Consumer Support Grant. This bill invests $70 million this biennium to fund the tentative contract agreement for these SEIU home care workers. Of that figure, $30 million is one-time funding. In addition, there's about $55 million in the tails. We don't have a full fiscal note, but your packet should include the budget change pages related to the contract, which this bill seeks to match. The contract agreement includes key provisions that help workers and their clients. 40-cent per hour raises for a subset of experienced workers in the programs, PCA Choice and CFSS budget models. And I'm looking at all of my opening remarks here, Mr. Chair, and I'm sure you wanted to keep it a little bit shorter, but
You're fine.
Okay, so for clients that have the most severe needs that require more than 10 hours a day of care, the contract improves the higher pay enhanced rate from a current 7.5% to 12.5%. To address the training bottleneck, $250,000 is added to the existing training programs and to expand language access. And home care workers will finally get a holiday pay when they work on Christmas and make it easier for workers and clients to find each other, so there's a $1.5 million online matching service. Too many PCAs leave this field because there's no way to save for retirement. And while this contract does not create or fund a retirement plan, it lays the foundation for a defined contribution retirement program. It invests $350,000 to create a joint state union body that would be the vehicle for a defined contribution retirement program. And any benefit would have to be agreed to in the future and funded by the legislature. As I mentioned in my opening, this agreement indirectly benefits programs outside of the SEIU bargaining unit. After DHS calculates the rate increase necessary to cover the cost in PCA Choice and the CFSS budget model, it provides the same rate increase to the traditional PCA and CFSS agency model. This rate increase goes directly to the providers and can be used to improve wages and benefits, although there's no legal obligation to do that. And finally, this is an open shop union. No member of the bargaining unit is required to pay dues or join SEIU, but all contract benefits are available to all members of the bargaining unit without regard to status. Home care workers serve disabled and elderly people, often at great sacrifice to their health and well-being. For generations, we have underinvested in this workforce, and it is disproportionately women and people of color.
Say that again.
Generations we have underinvested in this workforce, Mr. Chair. We have underinvested despite the fact that their work saves the state money by keeping people out of more expensive institutional care, and quite frankly, it lets people live independent, thriving lives at home. There has been long bipartisan support for these workers. I wish we could do more this year, but I'm glad we can do this much.
You have the A, thank you. I wanted to hear that again because we seem to forget, and you look at the cross sector there that you just mentioned it, right? You're talking about the majority of those working, the majority of those in this industry happen to be what you just said, right? And I think it's important that people are reminded because there's, as some politicians will say, brown, black, and indigenous, we want to do this equity, yet we look at our 144G providers, and who owned those are BIPOC, right? We know that. it's like, what are we doing to uplift? So I appreciate your comments on that. You have the A1 amendment that had some changes in there, including that fiscal piece that you had. So all those in favor of the A1 amendment, say aye.
Aye.
Opposed, same sign. Thank you. So now the bill is where you want it to be. You had your opening statement. You want to go right to Monica Flavin, and she can tell us in 2.5 hours why SEIU. You know what? It's just that 12 years ago, Monica, PCAs were making $7.25 an hour. I don't know how many times I've said this, but when the spotlight, the jurisdictional conversation of, PCA and childcare, and all of a sudden you got, right? And to see this happening put a spotlight on human services, which was a good thing, because all of a sudden it said, wait a minute, we have folks here that are working the jobs that people are, trying to find workers to do, and we're actually trying to get them on a pathway. And so I always appreciate reminding myself that 12 years ago, as I stayed up for 18 hours saying roll call to allow SEIU to form a union, it was one of those moments where they were making $7.25 an hour. So anyway, that's enough about me. Monica Flavin, tell us who you are.
Chair Hoffman and members of the committee, thank you, Senator Quade, for authoring this bill. My name is Monica Flavin. I live in Coon Rapids. I work in home care. I've worked in home care for over 8 years, and I'm testifying on behalf of my union, SEIU Healthcare Minnesota and Iowa. We represent over 55,000 healthcare workers. I'm asking please support Senate File 2640 because we should continue to support those who care for the most vulnerable. I myself did not expect to be a home care worker. I had a great career as a professional, but my daughter Naomi struggled with autism, and my husband became unable to care for himself after recurring bouts of cancer and a spinal injury. I tried to manage my job and 2 disabled family members with outside home care workers, but I could never find reliable staff. I changed jobs and reduced my hours so that I could start working as my own home care worker. Now, between home care work and part-time professional work, I work much longer hours and I make less than I did before. This contract gives me hope. The pay raise and the bonus will help. I might even be able to hire an outside caregiver and go back to work full-time due to this new matching service that could help me find more reliable caregivers. This contract does not immediately put any money into a retirement plan, but it does set up infrastructure for a 401k-like retirement program. I hope in our next contract we can begin to bargain over some kind of contribution. I myself am lucky that I can still contribute to a retirement plan through my employer, but to be frank, it will not be enough. So many home care workers have no retirement. So this is a big step forward, especially for them. Funding for these programs has always received strong bipartisan support, and I want to thank Senator Abeler for joining this bill as a co-author. In the House GOP, Senator Representative Danny Nadeau as the lead author. I know this committee strongly supports the elderly, the disabled, and those who care for them. I hope you can conclude this contract in your final budget. Thank you for hearing the bill and for your time.
Well, I was okay until you mentioned the other body, and you mentioned who the other person from the other body was, and that's Senate District 34, and how come I wasn't asked to be chief author on this if you had the chief author from the other body from 34A? Members, Senator Abeler.
Well, part of that, Mr. Chair, is perhaps because he used to be Ms. Flavin, the senator, in a different life. And so we won't ask you to decide who you love the most, but it's just, thank you for being here. This is a really important thing. And if there could be money to fix this, that would be awesome. So thank you for being here. And actually, Senator Hoffman probably represented you better than I do, but at least I'll do my best to keep up. So thank you.
Did you see that for the public record? Did you see that's Coon Rapids I had for 10 years? I know that Senator Utke, Senator Maye Quade, you probably want to connect with Senator Utke. He had some stuff that I think, and on the insurance side, I don't speak that language, but he does. And so I think that our role here is to get this to go to state and local government, and then come back here. Is that correct?
Mr. Chair, state and local government, yes. I apologize for not knowing the path after that.
No, okay. Laid over. Yeah, it's come, okay, so state and local government, they're getting laid over, so it's coming back to get laid, no?
Oh, no.
We're laying it over here, today?
Great.
We're not, did you get authority to not go to state and local government then? Because if
So
that's the case, that
authorized.
gives Senator Utke a lot of time. So yeah, Rick, come up here and talk to us. Will you, for the record, please introduce yourself?
Chair Hoffman, members of the committee, my name is Rick Varco, representing SEIU Healthcare Minnesota and Iowa. My understanding is because we don't have to ratify the contract anymore, we just have to fund it. It doesn't need to go to state and local government anymore. I could be wrong if Senate Council, like if nonpartisan staff say otherwise.
Ask Liam, I think I heard down here. Mr. Monahan, is that, you need time to cogitour him that? That's Latin for they will think.
Mr. Chair and members, the question would be about Section 1.
Yeah. Oh.
I mean, Mr. Varco's correct about the ratification issue.
That is correct.
But I don't know if it'd be state and local or labor or I'm not certain who has, off the top of my head, who has jurisdiction over Section 1.
Mr. Chair,
Senator Abeler.
why don't we just suspend discussion on this till somebody finds out if any of those committees want to see it? The worst thing to be would be you lay it over, find a way for pay for it, and they're like, oh, by the way. So, thanks.
Senator Rasmusson, to that point.
Thank you, Mr. Chair. The only thing I'm noticing here when looking at Section 1, and would just ask the bill author to maybe check in with Senator Frentz on it, because it's dealing with retirement fund trust. I just
That's
don't
it.
know
That's
if
what-
this
that's what
needs
he was
to
talking about. Yep.
actually have a hearing in the Pension Commission. And like an example of this would be on, secure choice or other things that maybe aren't truly pension, like state pension related. We've oftentimes had hearings in the Pension Commission, and the jurisdiction for anything for the Pension Commission is the Committee on State and Local Government.
With that, it sounds like there's a lot. I think we should just table, let's just table, Senator Maye Quade, do you want to go ahead and motion with Senate Files 2640? We'll table that until we get everything answered. Is that correct?
So moved, Mr. Chair.
So moved. Anybody agree with that? Say aye, aye. There you go. I don't even know if I had to do that. Senator Fateh said division. Do you guys want to, I'm going to take him outside. And Senator Coleman, this is your, welcome back to the committee that you served on for slightly a couple. Did you have fun on this committee? I just want to know that.
Mr. Chair, quite honestly, I bought 1,800 Post-its and have slowly been covering our Chief of Staff's office with them until I get back on this committee, so.
Oh, really?
Yeah, it's an environmental hazard, really.
Senator Rasmusson, are you hearing this? She wants to be back on this committee. Did you know that? Well, why can't we just have her come back on this committee? We could have her, can't we? Right? All right, there you go. Let's see what we can do about that. Senate File 2896, non-emergency medical transportation provisions and modifications. You got Buck McElphin and Phil Stahlberger here, right? Is that correct? Or are we just going to hear from Phil? We're going to hear from Buck. Can you do it in 1 minute or less? Because I think you got 30 seconds is wonderful. You got a pathway you want to go on this? My understanding is you want it to go to Finance Committee. Is that correct?
If we could dual track it, Mr. Chair, that'd be great.
Help me understand what you mean by dual tracking.
Finance as well.
You want to do that? So this
Yeah.
one, all right, fine with that. Folks, I think that's what people were up here were asking, so that's good. Senator Coleman, you have no amendments, so go ahead, talk about your bill.
Yeah, thank you, Mr. Chair. I know you guys are pressed for time. You've already heard this bill. It comes from the governor's budget proposal regarding non-emergency medical transportation changes, and you heard extensive testimony on it, and so it's just the exact same thing you heard in official bill format here. I'm happy to take any questions, and I know our testifiers said they've already said everything in front of this committee they need to say, so they'll be brief as well.
Senator Maye Quade.
Thank you, Mr. Chair. Thank you, Mr. Chair. Mr. Stahlberger is a constituent of mine, Senator Coleman, so I'm only offended that he didn't bring this bill to me first, but I'm wondering if I could join.
Absolutely.
Thank you.
Got that? You were all good on that one. So, any other members? No. Go ahead. Who's going first?
Oh, yeah.
Which guy in the blue tie?
I'll go first. Phil Stahlberger, Medical Transportation Management Health. Thanks for the opportunity. I'm going to keep my comments brief as well, since you heard me, 3 times on this issue so far. I think you know where I stand. Minnesota is a unique outlier on this proposal. This bill brings it into what most other states already do. So I'm happy to go into more detail if you want, but I will turn it over to Buck.
That's good. Thank you, Phil, for just validating that piece of it, because it's where we need to be. Buck, how about you?
Yeah, Mr. Chairman and members, Buck McAlpin at the Minnesota Ambulance Association and the R80 NEMT Coalition. Mr. Stahlberger and I talk about this issue often, and I appreciate the legislation coming forward. I think the key is, as we've talked about over the years with, 2004, Phil, 20 years with non-emergency transportation, that we really need to do something this session, right? And Senator Rasmusson and I have talked about it, and Abeler and many of you, is rural Minnesota, we have to have a focus on non-emergency transportation. And I think as we look at an RFP process to find some type of solution that's very software focused, especially, that we feel that we can work on a lot of these issues. And most importantly, with the governor's proposal, one thing we've always been concerned about is taking too much money out of that fund to really truly fund NEMT. And we continue to we'll work with Senator Coleman and the committee on what this could look like.
Thank you. Senator Rasmussen moves Senate File 2896.
Mr. Chair.
Senator Abeler, you stopped me before my sentence, so go ahead.
Oh, yeah. Well, I could still discuss the motion, I suppose. So this doesn't have the governor's spending cuts in it.
Say that. Sorry,
There's
Jim.
no money, the governor's budget numbers are not here. This is, I'm comforted by the 2 bookends there that, I don't remember if I've been to the table
They
agreeing on.
extracted the governor's language on this
Yeah, no,
one,
I don't remember them being at the table agreeing on hardly anything. So I think we're moving along, Mr. Chair. So I just want to make sure there's no money in this, because the governor's money, I think, is an unworkable money. It's just like waving at those guys back there. Thank you, Mr. Chair.
Do you want to get Elise Bailey down here to answer that question, Senator?
No.
Okay. Senator Rasmussen.
Thank you, Mr. Chair. And I guess the, one thing, and we don't have to get into it in depth today, but I do think the fiscal portion of this bill is really important. And the reason I would say this is in the governor's budget proposal, the governor is finding savings with this, which I don't necessarily have a problem with. If there are meaningful savings to be found that help state government run more efficiently, great, count me in. But the challenge is today, if you go to a place like Otter Tail County or Traverse County, Wilkin County, the places I represent, NEMT services just don't exist. It's just not even a thing. And so that's will be my question as we get to the fiscal portion of this, is how do we make sure that these services that people are supposed to be provided are actually there. And I think, especially in our work on the EMS task force, having kind of a non-existent NEMT service in rural areas has put a lot of pressure on rural ambulances, where they become an alternative, and they are, frankly, a more expensive alternative than NEMT. So I think it's just important that we get that balance right, and we understand where the savings are coming from and where potential reinvestment would be required. But again, I'm all for government efficiency, all for finding savings. Just want to make sure that the services are able to be provided. So thank you, Mr. Chair, and I appreciate the work on this bill.
You too. Senator Abeler.
Well, just to do the caveat, I hope this doesn't imply the governor's target, because in my opinion, taking money out of this system, however efficiently you can run it, still means people have costs, and their costs have gone up mammothly. So I don't know, I don't care where you send it, it's going to have to land somewhere, but it's being sent to finance with a 0 target.
Yeah, I don't know. That's a good question.
I don't mind mailing it off to anywhere.
That was the question, and David, and when I came over to Senator Rasmussen, I said, she wants to dual track this, what makes sense? And everybody said Finance Committee. I don't know the answer to that. I think, Kyle, do you have an answer to that one? Does the 0 target go there, or do they get to recoup the savings on that? Do you know how that works?
Mr. Chair, so as I understand it, this language reflects the governor's proposal. The reductions in the governor's proposal are an assumed amount based on what the department has seen in other states when they switch from a fee-for-service to a managed care. So I would expect the reductions that are booked in the governor's budget to be associated with this language.
Well, Mr. Chair, this should not move then until we can be assured. I mean, Senator Coleman, you don't intend to remove, what, $60 million from the program. And I think that we're happy that there's an agreement on how maybe to do it. But if you're going to save money, taking out an NEMT is not where you want to do it. So, I mean, I think really you just want to leave it here till we can. You don't want to be the author of ruining something like.
Wherever you guys.
So maybe we're at the same debate. So this is good. I mean, this is the conversation that needs to happen. We're at the same debate as we were the first bill. So is it your suggestion then, team, that we leave it here, table it, or just lay it over and leave it here? Because she really wanted to dual track this, you guys, and I don't know. Anyone? Yeah, go ahead, Senator Rasmusson.
Thank you, Mr. Chair, and I have a question for Mr. Raymond. So where would the fiscal component for this bill show up? Would that be in a budget bill, or like where would that piece show up? Because there isn't a change in appropriations in the bill before the committee. It's basically the policy telling the Department of Human Services to go and set up a single administrator for NEMT for the state.
Mr. Raymond.
Mr. Chair, Senator Rasmusson, so as provided in the change pages, the reduction would be to MA. There would also be a cost associated with the NEMT vendor contracts, but the net effect of those, the reduction associated with the reimbursement system change would be about $35.5 million in the first biennium and about just under $150 million in the tails. So that's where the reduction would actually occur. It would show up as a reduction in the MA appropriation in the appropriations article of the Human Services bill.
Senator Abeler, yeah.
Well, just to caution, let's say this is a great idea and there's just way too much money in this system, which I don't agree with. You're sending away $180 million or whatever.
Especially when John Marty still owes this committee $178 million.
This would be giving John Marty $180 million to go buy whatever he wants. So just telling you.
Well, Mr. Chair, I don't want to do that, so.
All right, so lay it over. So you know what? Thank you. This is welcome to the committee. You should be back here with us because these are the conversations we have. We're going to lay. Everybody says lay this over, so we're going to lay this one over. Thank you very much. So, Senator Abeler moves Senate File 2896 be laid over for possible inclusion.
Thank you.
So, thank you so much. That was good conversation. Senator Dibble, Senate File 2972. And then you're doing private equity company acquisitions of nursing homes and assisted living facilities regulation. This is the conversation that we've been having for many, many years. You got an update for us and a bill, and you got Sean Burke and Paricha Rodina, and it looks like Aaron Hubert and Kyle Burnt are coming down too. Do you guys want to all be at the same table? Or you want to just wait till what you guys are good? Senator Dibble, you have an A1 amendment.
Mr. Chair, I'll move it.
Senator Abeler moves the A1 amendment. All those in favor say aye. Aye, opposed, same sign. Senator Dibble, now the bill is in the form that you want. It's all yours.
Thank you, Mr. Chair and members. I appreciate the opportunity to present this bill. It is, like you said, has to do with the purchase by for-profit entities, that's the expression we use now with the A1 amendment having been adopted, but particularly those who are equity investors of nursing homes and assisted living facilities in Minnesota, because it has proven to be extremely harmful for residents and staff. A recent study in the Gerontological Society of America's journal found that new for-profit owners of nursing homes in Minnesota are primarily from out of state, including private equity firms. And the research demonstrates that ownership type influences nursing home quality. For-profit ownership, especially private equity ownership, has been correlated with higher rents and costs for services, staffing cuts and lower quality of care, lower facility ratings, increased health code violations, declines in resident mobility, increased levels of pain of residents, increased emergency room visits and hospitalizations, higher mortality rates. We've encountered very complex corporate structures with entangled webs of affiliated companies, in these takeovers, and it is often very difficult to find who is accountable for the violations and deficiencies. Self-dealing is another characteristic of these takeovers. Often, real estate trusts owned by the same people extract excessive rents from residents, and outside care and services are also provided by companies owned by those same people. And of course, our interest here today are the public dollars through Medicare and Medicaid, as well as other public dollars that support those in assisted living. And they are paid to these companies without providing the commensurate quality of care. Another common practice is to extract value from the facilities, neglect maintenance and infrastructure to maximize profit at the expense of care, strip assets, and walk away. So, Mr. Chair, this bill seeks to address that in a number of ways. I just wanted to point out a couple of other pieces of evidence, so you're not just simply taking my word for it. This is from the National Bureau of Economic Research, nonpartisan research firm that demonstrates all of the same elements that I just described. Patient mortality rates during a nursing home stay and subsequent 90 days is 10% higher at facilities owned by private equity firms than at skilled nursing facilities overall. Cash on hand declines by 38% after a private takeover, leaves these homes hard pressed to respond to something like a sudden need for personal protective equipment during, I don't know, a pandemic. Cutting costs causes the reduction in staffing levels. They see a 3% decline in hours compared with industry average. There's a push that private equity ownership shift operating costs away from staffing towards those profit drivers for those funds, for those investors in the funds that they hold. And there are higher charges that result. As I mentioned earlier, the overall bill is more than 10% higher if a patient goes to a private equity-owned nursing home than another home. The higher fees do not translate into better care, as measured by key Medicare indicators. Patients admitted are 50% more likely to be placed on antipsychotic medication because sedating them rather than applying behavioral therapy reduces staffing needs. Patients experience a greater decline in mobility and increased levels of pain. We're going to hear a little bit about the actual experience that we've observed from the ombudsman, so I won't go into all of that, but this has occurred specifically in very, very distressing levels at two major facilities that are in my district that I've been out to see and meet with and visit with my constituents who report many, many instances of the quality of their lives and the quality of their care deteriorating precipitously after the takeover of a for-profit entity at those two facilities, very large facilities in my district. To the bill, I'll try to summarize it very quickly, Mr. Chair. What it does is it adds definition to who the controlling person is in the statute, to those who have at least a 5% interest in a privately held corporation that takes over. That's, of course, an effort to create more transparency, and that's true for both the nursing home, skilled nursing facility side, as well as for assisted living. So those are in sections 1 and section 2. In section 3 on page 4, there's a new definition in the statute for both nursing homes and assisted living on what ownership means to include purchase, lease, transfer, exchange, et cetera. In section 4, we have some notice and transparency provisions so that at least 120 days prior to the transfer of ownership or control of a nonprofit facility to a for-profit entity, the facility must provide a written notice to the Attorney General, Department of Health, Department of Human Services of the intent to transfer the ownership, and the notice must include a number of elements. I won't go into all of those. You can read them yourself. But it includes things like who it is, if they've had previous filings, their balance sheet, the condition of the buildings, an affidavit with a great deal of really important information is required on financial ability, crimes, past litigation, liens, complaints, the level of investment and capital of the facility, et cetera. Section 6 is, Section 5 now, which was Section 6, you find on page 9, is really the meat of the bill, which outlines some of the prohibited practices after these facilities are taken over. not interfering with the professional judgment of the providers on site, no unequal treatment regarding charges based on payer type, cannot strip the assets from the facility, can't engage in self-dealing. You have to spend at least 75% of the public receipts on programs and patient care, et cetera. You can't raise housing costs inordinately, you can't allow the facility to deteriorate. And in the case of nursing homes, you have to strive to improve the CMS rating if it is at 1 or 2 stars, and you can't do anything that would cause a diminishment of a CMS rating if it's at least 3 stars. And then in the new Section 6, the Attorney General is given the authority to enforce under these laws. With that, Mr. Chair, we can go to Parice Rudina, who represents the Ombudsman for long-term care.
Thank you. Madam Ombudsman, welcome to the committee.
Thank you, Chair Hoffman, committee members. My name is Parice Rudina with the Office of Ombudsman for Long-Term Care. Today I am here as a member of the Consumer Advocates Coalition. Thank you for the opportunity to testify in support of SF 2972, and thank you, Senator Dibble, for your championing of this effort and carrying this important bill. OOLTC is very concerned about the reports we receive from residents before, during, and after a change of ownership from a nonprofit to a for-profit nursing home or assisted living facility. Residents have reported to us an overall reduction in quality of care after a takeover of their facility by a for-profit entity. Residents tell us that there are fewer staff employed at the facility than before. Fewer supplies are available, food quality reduces, and some residents are targeted for involuntary discharge or contract termination based on their payment source. Complaints to our office frequently increase after a takeover by a for-profit entity, in some cases by as much as 100% in the months following such a takeover. Residents experience everything from missing showers due to not enough towels being available for residents, to the supply of incontinence products running out so that a resident is forced to wear a product that is either too large or too small, to billing complications, to a dangerous lack of building maintenance. I'd like to draw your attention to a letter from a resident, John, that's in your packet. He gives a very vivid description of the changes he has experienced due to this kind of takeover, including a switch to incontinence products that he describes as being as protective as a screen door. To be clear, there are for-profit facilities who do not engage in these harmful practices. SF 2972 attempts to ensure that there are mechanisms in place to prevent the identified harms that are increasingly occurring when a nonprofit facility is taken over. For those for-profit facilities who do not engage in the practices the amendment would prohibit, there would be no impact. This bill ensures that the residents who need and deserve a high quality of care receive it. But there is clear evidence in Minnesota and nationwide that some owners are extracting monies out of nursing home and assisted living operating budgets at the expense of residents and their care. This impedes the good work done by the staff and harms the health and well-being of residents. For these reasons, we support this bill. Thank you.
Thank you. I did have my list. I have it again. Let's go. No, you're just hanging out. You want to maybe create a couple more chairs if the pages could? If you're going to hang out, have Kyle and Aaron come on up here then. And then, right? Yes. So Sean, I had you down. You're good. That's fine. Thank you. Who's going first? All right. For the record, please state who you are.
Thank you, Mr. Chair. Great to be back once again. My name is Kyle Burnt. I'm here today on behalf of the Long-Term Care Imperative. Appreciate the opportunity to testify in committee today in opposition to Senate File 2972. We have not had much time to analyze the proposal as it was introduced on Monday and the amendment we saw just last night, so we're going to stay a little bit high level on this. The proposal to regulate private acquisitions could result in increased costs, administrative complexity, and reduced flexibility in managing facilities. While the intention may be to protect residents and ensure quality care, the practical impact of these regulations could undermine the ability of nonprofit providers to efficiently operate and make strategic decisions and may limit market options to purchase and continue operations of a facility. We have some ownership information on nursing home facilities related to nonprofit and for-profit status. In July 2014, 60% of nursing facilities were owned by nonprofits. Now, nearly 11 years later, on March 2025, 59% of facilities are owned by nonprofits. During that same time, Minnesota saw roughly 40 nursing home facility closures.
Is that number, are those the numbers? Because last year, we required nursing facility owners and operators to report the related party transactions and costs associated with leases and rent. Is that all? Do you have all that information? We asked the department to do that. Are you getting those numbers from the department? Sorry to interrupt you, but it dawned on me, and it's, you know.
I do not have that at my fingertips.
So maybe when we're getting through this conversation, if somebody from the department could possibly be prepared to come down here and have a conversation with this committee, that would be wonderful, because there are a couple of things as a follow-up to that. So sorry I interrupt you, Kyle, but it just dawned on me. Senator.
As long as you've stopped him, I want him to back up just a little bit and give me those two numbers again.
Okay. Yeah. Kyle, will you give those numbers again, please?
July 2014, 60% of nursing facilities were owned by nonprofits. March 2025, 59% of nursing facilities were owned by nonprofits.
Mr. Chair.
Senator Maye Quade.
Thank you, Mr. Chair. Would you be willing to tell us the percentage of for-profit from 2014 to 2025?
I don't have that in my notes. I could
Mr.
find
Chair.
it.
Senator Maye Quade.
Thank you, Mr. Chair. You sent them to me. Can I read them? Okay.
Absolutely.
In July of 2014, 32% were for-profit, and in March of 2025, 33% were nonprofit, or for-profit.
For-profit.
For-profit, excuse me.
That's a third. Okay. All right. Thank you. Thank you for letting us be our committee and stop and ask questions.
Of course.
Keep going, Kyle, if you can.
Absolutely. Thank you, Mr. Chair. As constructed, the bill would discourage private investment in the sector. This would lead to fewer options and resources for providers to improve infrastructure and services, or even stay open to provide services to the community. The overall impact may result in less investment and fewer choices for residents, especially in underserved areas where investments are crucial. We are opposed to the proposal. We believe the state should instead focus on incentivizing all nursing homes, no matter what the business structure, to improve the metrics that drive quality for our residents. With that, I will turn over testimony to Ms. Hubert. I'll just sit here.
Hey, for the record. You can just, swap over and get the. Do you guys remember Bob Barker? Do you remember the length? This is like you remember that? That's what it looks like. It's that wired. It was wired. I just always see that and I think of Bob Barker for some reason. So, Erin, for the record.
Thank you, Mr. Chair, members of the committee. For the record, my name is Erin Hubert, and I am also here with the Long-Term Care Imperative. Again, largely high-level concerns as we're still trying to go through the details of the bill and then the amendment. And I would start by saying that in the 3 years since I have been in this position, I've been aware of a limited number of instances where a local nursing home was struggling financially. Perhaps they required a really significant asset update, or they spent their entire reserve to cover pandemic-related expenses. And in nearly all of those instances, it is my understanding that they first reached out to another local, usually nonprofit-owned nursing home to try to make a case for partnership. And the reality is that most nursing homes, especially post-pandemic, were in a very economically fragile position, and therefore were not in a place where they could take on another care center. So while we are trying to go through the details of the bill and the underlying amendment, I think one thing I wanted to point out on behalf of another association is, 51% of assisted living providers today are for-profit licensed AL providers who are serving those clients in those 6 or fewer settings. And they are BIPOC owned and they serve BIPOC clients. And so I think we are all trying to figure out how they can continue to serve individuals in the context of this bill. I think it's helpful to hear the author and the proponents describe it as a nonprofit to for-profit conversion, but I think there are just some considerations that folks are trying to understand. And then lastly, I would like to just take this opportunity to take a step back on the session overall. We have Medicaid cuts proposed by the governor, which would drastically impact a nursing home's ability to pay their bills and their labor costs. We have a nearly $200 million expense in unfunded mandates by the Nursing Home Workforce Standards Board. The Healthcare and Human Services Committee is hearing the governor's proposal to raise assisted living fees by 43%. And now this proposal is eliminating a tool for providers to seek funding and capital. I think that the concerns from seniors and families that we hear about the affordability of care are sincere and real. And I think that's why the legislature also has to be honest about the impact of fee hikes, unfunded mandates, Medicaid cuts, and then limiting access to capital. Thank you for the opportunity to testify today.
Remember when you were first elected, and you brought up the should we have the conversation about equalization? You remember that? And everybody on the committee said, been there, done that kind of thing. It's like, I'm not suggesting that we have that conversation, but since everybody said, no, I'm just kidding on that one. Let's go to Senator Rasmusson, Senator Gruenhagen, and then Senator Maye Quade.
Thank you, Mr. Chair. I guess question for the bill author. I guess Senator Dibble, is this a proposal from the Minnesota Department of Health, or is there an agency that's proposing this? Or I'm just kind of trying to wonder where the genesis of the language came from.
Senator.
Mr. Chair, well, it's coming from me in response to the experience of my constituents at two of my major facilities, one skilled nursing, the other is assisted living. But as it happens, it wasn't hard to find a lot of support. I was drawn into this by the ombudsman, made aware of what was going on at these facilities. By Ms. Radina and in her office, and then engaged in conversations with Legal Aid, the Minnesota Elder Justice Center, the Alzheimer's Association, AARP, and of course, Elder Voice supports this as well. And I think there's a letter in your packet that has the coalition logos at the top. And so the conversation ensued, and we developed these proposals.
Mr. Chair, follow up.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Dibble. Further follow-up, because in for these types of facilities, the regulator, especially over quality, safety, those standards, is the Minnesota Department of Health. Obviously, the Department of Human Services plays a role in financing these facilities. Do those agencies support this language? Are they asking for this language?
Mr. Chair, not that I'm Senator Rasmusson, good question. I think the short answer is no. I don't know if they support it or not, but they have not initiated any policy change in this arena that I'm aware of.
Go ahead, Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Dibble. And I guess that would be, I'd be curious to, have them weigh in on this, because they look at our nursing home systems, they look at quality, they give quality scores. They're the agencies that are dealing with these entities every day, and so, would love to hear their input on a bill like this before we move it out of committee. And I guess, one of the other concerns I have is that oftentimes, if this bill's focused on the conversions from nonprofits to for-profits, the reason that those are occurring is because the nonprofits are not financially viable. And I worry that the alternative, if this bill goes into place, is just closures. And that is what it could ultimately end up with, which could have other consequences for our seniors. And so I guess one of the challenges I have with this bill is it seems very focused on the type of ownership, on the transactions. And I think if we see quality, safety, health concerns at providers of any type, we should be making sure that their regulators, Minnesota Department of Health, others have the regulatory tools to address that. Because one of the things that I worry about is if you have a nursing home that's in a distressed situation, this limits the potential options. It adds in regulatory uncertainty. Oftentimes there are counterparties. If you have a nursing home that is financially stressed, they might have be working with a lender. They might be in default on a loan. And this just adds risk and uncertainty around any type of restructuring that they could go through. And these types of situations with these closures, and I know, Senator Gruenhagen and others on this committee have had these happen in our own communities, and I just worry about the implications of eliminating this type of option. And if we do have issues, I think we should be working with the regulators who are there on the ground and making sure they have the tools to ensure that people are safe under our care.
You're raising up an interesting point. I remember a few years ago in Coon Rapids, Minnesota, of all places, we couldn't identify who the owner of it was one of those, where, and I remember Senator Dibble had been working on this stuff for a while based upon those instances. But you raise up another point. It's like, is this setting us to here? I mean, I think this pathway is going to go to judiciary, come back to us, I believe, and then we get to hang on it. So Senator Rasmusson. And then we're going to go to Gruenhagen.
Mr. Chair, I'd like to respond to Senator Rasmusson.
Oh, I'm sorry. Yeah. I was looking at you, and you're like, I want to respond to that. And I was like, wait. So let's go to Senator Dibble and then come back. You can just interact.
Right. So I would just encourage the committee to read the bill closely and not shoot right past what the bill actually requires and asks for. It doesn't prevent the takeover of nonprofits by for-profits. It simply sets up some requirements around conditions and transparency and disclosure, notice, as well as making sure that these entities are providing the kinds of service we would expect in exchange for the public resources that we expend to care for these individuals. And I just suggest that it's a prudent bill because the evidence is overwhelming that in many instances, when we have these kinds of conversions from nonprofit to for-profit, patient outcomes goes down while expense goes up. And so we get the opposite in terms of outcomes relative to the public effort and public expenditure. So it's not in any way a barrier or a disincentive. It's making sure that we're standing up for the public's interest when these private transactions occur.
Senator Rasmusson.
Thank you,
then
Mr.
let's
Chair.
go to Gruenhagen. And then you're going to be number 5, Senator Zainab.
Thank you, Mr. Chair, and thank you, Senator Dibble. And I do think, we heard from the long-term care imperative that, from their reading of the bill, that this would be a real barrier to these types of transactions from taking place. And one other, question I have is, why the Attorney General? And, again, why is the Attorney General going to be the individual who's reviewing and approving these transactions when, frankly, the Attorney General doesn't do a whole lot in the
Mr. Chair,
health?
sorry to interrupt.
No.
That part has been taken out in the amendment.
That was the amendment took that out of there, and because you look at even currently, the healthcare transactions are reviewed by the Attorney General's office, right? Even though there's the Mayo settlement stuff, but that was taken out in the amendment, Senator Rasmusson.
And then my question, Mr. Chair, and thank you, Senator Dibble, for clarifying that. Then who is going to be reviewing and approving these transactions?
The Department of Health currently, as they do now. It just makes sure that they're receiving the kind of information that we would want.
Thank you, Mr.
Right
Chair.
now, we don't get a lot of that information that we need. Who it is, what their record is, what they plan to do, what their balance sheet looks like, et cetera.
Thank you, Mr. Chair. And I guess, do we have anyone here from the Department of Health to talk to this proposal, or?
We have queued up the Department of Human Services to kind of talk about the thing we required on the owners and operators to report. I don't see anybody from MDH that wants to. They don't usually come. Did you ever see that movie when the guy? Did you ever see that movie? Anyone?
Ferris Bueller's Day Off.
Anyone? Senator.
Thank you, Mr. Chair. I just, I think it's important, if we're going to be giving this to Minnesota Department of Health, I just think we should have a chance to talk with them about these new responsibilities that they'd be taking on under the bill.
Yeah. No, I mean, this has always been, this is that conversation. Let's go to Gruenhagen and
But
then.
Mr. Chair, to that point.
Yeah, go ahead, Jim.
You'll have to discuss with Senator Whitman if this would appropriately come to her committee as well after clear judiciary.
After judiciary.
So if they're approving it, then that would just be a normal thought.
Is that on your radar, Senator Wickland?
It isn't one that is on our radar, but we can review it.
All right. Huh? Good? All right. Senator Gruenhagen. Aren't you glad you joined our committee, Glenn? I mean, look at these conversations. These are real-life conversations, you know?
I'll withhold
What's
final
that?
comment till the end, okay?
Oh, wait, Glenn, we got somebody from the,
Well, that's what I was going to say, somebody,
thank you for pointing that out to me. I appreciate that. Can you state your name for the record, please, and Senator Rasmusson's questions and Dibble's interaction, and I'm going to sit back.
Hi, Mr. Chair, members of the committee. Lisa Timian, Department of Health Legislative Director. I will say for this bill, we have not really had a chance to do our full analysis on this yet, and so we'd really welcome some additional time to be able to talk to the authors and to have more discussions around this.
Thank you, Mr. Chair, and I appreciate, thank you for being here today and providing that context. And I just think, Mr. Chair, that, you know, especially given that this bill was introduced this week, we had a pretty major amendment. We'd just, you know, like to have some time to hear from the Minnesota Department of Health and just, you know, other stakeholders on the implications that the bill has before we move it out.
Senator Gruenhagen.
oh, thank you, Mr. Chair.
Or just wait, go back. Senator Abeler, did you have something to that point before this Department of Health came up? Because otherwise you want to just get in the queue. We'll just go to Senator Gruenhagen. Go ahead, Glenn.
Oh, thank you. Yeah, I had many of the same concerns that Senator Rasmussen has, and I appreciate the Minnesota Department of Health weighing in on this bill because, yeah, I know they haven't reviewed it yet. I know it's well-intended. None of us want a nursing home or assisted living residents to get abused in any way. We all agree on that, okay? The thing is that, and I guess this question would be for the Minnesota Department of Health, if some of the things that were said here today in terms of alleged abuse, is that something that a resident or resident's family could file a complaint on, and would the Minnesota Department of Health actually investigate that?
Sure, Mr. Chair, members of the committee, I would say that we do have the MARC process and the, which is an 800 number and also an online complaint process. And so there's a number of different ways that they get, complaints do get triaged. I'm not sure if it would address every single aspect that was raised today, but we would certainly look into them if they were brought to our attention.
Thank you. Thank you for that response. So evidently, most of the abuses possibly could be investigated, is the way I understood that.
Mr. Chair, members of the committee, again, I would want to have a little bit more time to engage with the language and the intent on this bill, but I think we would be more than happy to continue working with the author to sort this out.
That's always a good thing. Senator Gruenhagen.
Oh, thank you. Thanks for that response. I would like to call back up Mr. Brandt and Ms. Hubert. If you'd come back up to the testifying table.
Call back up. Is that something you guys used to do years ago over in the other body? Call back up. I love that. I've never, that's cool. Call back up. I like that.
Appreciate you like my language. No, you know, in my district, I've lost 2 nursing homes, okay, just in the last few years in Arlington and Winthrop. And, you know, the most recent one was in Arlington, and I went and visited them as soon as I found out, the management, as soon as I found out. Well, I just said, do you have places to place these residents? And the exact response was, I hope so, okay? I mean, think about that. You've got some of those vulnerable people in the state of Minnesota, and the management says, I hope so, okay? And so as these nonprofits buy some of these nursing homes or purchase them in the transaction, are they doing it primarily because the existing nonprofit nursing home is having a hard time meeting its expenses and, you know, versus having to close it? In other words, are we taking an option away from these nursing homes or assisted living that to stay open versus having to close?
It's a great question. You guys got an answer for that, or is this going to be something you take when the bill goes to judiciary? Because I have a feeling we're going to be, this is good conversation, so what do you got? What are you hearing?
Mr. Chair, Senator Gruenhagen, thanks for the question. I'm going to speak in generalities because I don't want to get too specific to any facility, but it is, you know, to my testimony, at least in the limited experience that I've had in this role, the vast majority of times, if we're talking about a change in ownership, it is largely because the existing owner or an operator can't fulfill its financial obligations and is looking for additional support so that it doesn't have to close, which is a very controlled process with the Department of Health already.
Ms. Rodina, is that, you looked like you had is there something you want to add to that, to Senator Gruenhagen's question?
Chair
As the
Hoffman.
ombudsman?
Thank you. Senator Gruenhagen, yes, I agree. I mean, nobody wants to see these things happen, and I think a key aim of the bill is to be preventative in nature, not just responsive once the abuse has already happened. And I think that's an important factor here that I think we probably all agree on as well, that we want to prevent. I think there's a question of what feels good enough? You know, do we think this is good enough to have a for-profit entity take over a nursing home and have some of these results that we're seeing in a pattern? Or do we think there's something better that can happen? And I think some of the prohibited practices that are in this bill helps to, again, still leave an avenue open for a for-profit entity to purchase a nonprofit, but ensure that once they have made that purchase, they are using those funds from taxpayer dollars and people's lifetime savings the way they're supposed to.
Senator Gruenhagen.
Oh, thank you for that response. Yeah, I see it slightly different because obviously some nursing homes in my area are not doing very well. I've met with several of them, and they're just barely hanging on. And to me, if you look at this bill, it puts a lot of hoops up in front of a for-profit to dive in, and I think it would have a chilling effect for a for-profit to actually take over a nonprofit that is struggling financially. And I'm hopeful the governor's budget doesn't go through because that's going to be millions of dollars of additional cuts in my district and all across this state for our most vulnerable. But I know the bill's well-intended. None of us want abuse of, residents in these areas. But I just think this overcomplicates, and I think we should try to expand in the areas that we already have if there needs to be additional requirements as far as addressing these abuse, rather than creating another bill. We could have enough bills to create utopia for assisted living and nursing home. Problem is, there might not be any left, okay? They might all be closed. So, so I just have a lot of pause on this bill, and I hope that the author will work with the other side to come to some type of peace in the valley that protects residents but doesn't put too much of a chill on nursing homes that need this option available in order to stay open. Thank you, Mr. Chair.
Mr. Chair, I agree with Senator Gruenhagen more than he probably knows or appreciates.
That probably scares both of us.
Yeah. I come at this from a couple of different perspectives based on my life experience. One is, that, of course, I have, a number of long-term care facilities of all types in my district, and I interact with my constituents who live in them all the time, both for-profit and not-for-profit, skilled nursing, assisted living, other forms as well. I have a sister, I think I've mentioned that before, who's a licensed practical nurse, works in one of the facilities in my district. As a side hustle, I used to help a friend of mine who was a past administrator of skilled nursing facilities and then became a consultant, and I helped him do the analysis of why a number of the smaller, previously owned mom and pop nursing homes in small towns were taken over by a large system still nonprofit, but a large system, had, some substantial debt ratio relative to their cost of operating, and did a lot of deep dive analysis of why these small nursing homes in small towns were struggling so much. So I have some pretty intimate familiarity with how these facilities operate. The margins are very tight, et cetera. And so I'm sympathetic. And I understand what they mean. This is where seniors are going to go to live so they can stay close to their community, their families, et cetera. They're usually large employers in these towns. So that's really important. And what happens oftentimes, what we discovered in these smaller nursing homes was that people weren't being paid enough. And if they were in the Mayo market shed, employment shed, they would go work for Mayo, or even if a large retailer opened up at the edge of town, they go work for the retailer, so they couldn't keep their census up, and they would just start losing money hand over fist. So interestingly, when these for-profit companies come in, they drive those wages down, and they start squeezing more and more, and also, start, running bare bones operations. And so I think there's something in here for everyone to appreciate and want. What we're looking for, I think, is fairly simple, fairly straightforward. Who are the controlling interests, the controlling individuals of these entities? What is their record? What is their balance sheet? What is their business plan? The kind of information that we don't collect currently. So, and with enough time to evaluate all that, we have some better time standards. And then once a for-profit entity does take over, which, if that's necessary, that's fine. Making sure that the public's interest, that the profit motive doesn't displace the public's interest. Because once the profit motive gets into healthcare delivery, all of a sudden, there's a different driver that drives and incents certain kinds of behavior that might not end up being very good for our mothers and our fathers who are in these facilities. We heard the stories. I have a long, long list. I have a giant report here from one of my assisted living facilities of what is happening today to their lives, and it is terrible. You have the letter from one of my constituents who lives in one of those facilities. Repeat that letter by about 100. That's what's happening in people's lives. So I'm trying to find the right balance. I will, of course, always work with the industry interests. My door is always wide open to everyone, and I always take in information and make changes to my legislation as it moves forward. And of course, I have a close relationship with the Department of Health. If Department of Human Services has a role here, of course, I want to talk to them as well. So sorry, that was a little long-winded.
No, you actually, that's exactly to the point, because then Senator Gruenhagen and Senator Fateh said the same thing. Matter of fact, he's not going to have any more questions. He just said, pull me off that, because Senator Dibble has made it very clear that he's going to work with you guys. He wants to, when it comes back to our committee, to show us the progress that was made. So then, we kind of hold that to that. So, yeah, Glenn, there's like 6 people, and we're looking at the time, unless you're going to buy dinner tonight. So,
okay,
go ahead. You're good, Glenn. You're asking great.
Of me.
I love it. No, you keep going.
No, Senator Dibble, I know you mean well. Okay, I know the bill means well. I just would like to see a little more balance on that. And I had my mom a couple years ago was in a nursing home, and obviously I want her to have good treatment. God rest her soul, she passed away. My mother-in-law, who's 99 years old, is in assisted living, and she's not far from going to a nursing home, and I want her to have good care. So I just don't want to chill the atmosphere too much of assisted living and nursing homes that have an option to stay open versus closing their doors. And we have the Minnesota Department of Health testifying that they will respond to some of these egregious problems. And I just think somehow in between there, things might work out a little bit better. And thanks for working with the individuals who testified about their concerns on this bill. Thank you, Mr. Chair.
Thank you, Senator Gruenhagen. Go to Senator Maye Quade, then Senator Abeler, then Senator Mohamed, then Senator Utke, and then that's the end of our thing, unless you guys want to, slow roll it to know he's going to come back and show. He said he's going to work and come back with progress. I love that. I'm hearing that. Senator Maye Quade.
Thank you, Mr. Chair. And, there's a really different take from some of my colleagues on this committee. I mean, when we're talking about private equity in particular, these are not long-term investments. These are stakeholders who invest for a short period of time to bolster earnings and then sell it off. And so there's a part of me that's wondering if some of these closures have actually been because of private equity buying up nursing homes, squeezing them for as much money as they can, and then not being able to, sell them or spin them off or taking them apart. There was a sentence in this packet that said, private equity in nursing home care is disturbing, and that is the perfect way to describe it. The profit motivation for providing care to, and let's be really clear too, there's a difference between hi, Jordan and I own a nursing home and we make profit from it, and having a LLC that pools capital from institutional investors and high net worth individuals to invest in companies for a short period of time before selling it off or spinning it off or taking it apart. And they charge a performance-based fee. I mean, this is just wild that I'm saying capital and capital gains taxes and leasing a building back to people when we're talking about nursing homes. But I do want to mention too that this isn't the Vice President of Health Policy and Regulatory Affairs at Leading Age, which is one of the two people in long-term care imperative, says, research shows that ownership and changes in ownership, this was January of this year, in ownership data provide valuable insights into how business consolidation can affect access to care. The pressure to generate high short-term profits under private equity ownership may prompt nursing homes to cut investments in staffing, services, supplies, or equipment, potentially harming the quality of care. That's from the folks who are sitting here testifying against this. There's systemic issues and transparency. Of course there are. And so I think that your bill, Senator Dibble, is a really good start, but I don't know how we can continue private equity in things that we need as public goods, like our healthcare system in general, like nursing homes, because it is destroying these systems. And so, I know we heard numbers, what percent were owned, what number we had in 2014 and what we have today, but I genuinely believe that part of the problem, and there are other problems, right? There are other problems, but I think private equity is its own specific problem to healthcare in general, and in particular when we're talking about the healthcare to seniors. So I just, I want you to continue with your bill, Senator Dibble, and I want to keep going because I would really like to rein this in and have high net worth individuals and institutional investors who are charging 2% of assets under management that cover operational costs and performance-based fees so that they don't pay carried interest taxes as capital gains rather than income. I'd love that out of nursing homes, to be quite honest with you. So I just, this has been a really weird conversation so far of focusing on not that, because that's what this is about. And I appreciate this bill coming forward. So I'm having a hard time thinking of Medicaid dollars going to the profit margins of high net worth individuals and investors. I don't like that. So thank you, Senator Dibble.
Senator Maye Quade, thank you. Senator Abeler.
Oh, thank you. And I appreciate the discussion and kind of blend a lot of the comments here. Is this a problem today? A little, maybe. Is it when do you want to fix the problem before it gets to be too bad? And nothing against private investors specifically, but when they've gotten involved in mobile home park purchases, they have totally run over families with no money. They raise the rents from $500 to $900, and we're in the housing committee in some of these low-income tax credit projects. Companies like that rhymes with Dominium have taken these programs and invested actually very little of their money, except they have their credit, and they have just totally raked these seniors over the coals to make money. And you wonder where the ethics are. In the healthcare system, you don't have to go very long into the discussion to find out where companies. When I started 46 years ago, it was all service. Nobody talked about money. These days, all we do is talk about money, profit margins, and the equity people. I mean, God bless them for making $1 and glad they're successful. But we should have done something then to put guardrails around. And so I hope that, Senator Dibble, you're a good author on this, and that the care providers and the imperative are willing to find a way to make sure that this doesn't come their way. Because I can tell you, I know the two people here representing the imperative do not want seniors to come to harm for any reason. And I will tell you, I'm sure that the whole organization as an organization does not want to. But I can tell you also, Mr. Chair, and anybody else who cares, that once we get a dozen of these, 15 of them, now they're members, and they have to look after their members. So then the associations will be more hamstrung. And so I appreciate what you're doing. I really didn't, the details of the bill I've not paid any attention to, but the theme I think is very important, and I support the effort. And we need to do the same thing in housing now, and just at least limit the harm to what's happened, where people buy up buildings on the programs on the cheap. And I want to remind you, with the VBR method, you want to buy a failing nursing home. Just go give them 30 cents on the dollar or whatever. The problem with the delay is nobody has the capital to handle the delay. Oh, wait, maybe one of these firms, these companies have just enough money to raise the rates to $30 for every worker there. Hey, good for the workers. And they're going to have all the workers come there, and everybody else who's in there just trying to do their work is going to be at a disadvantage. They won't be able to find staff. They might run them really well. But the fiscal cost of not controlling this, especially if we shrink up the 18-month thing, which is a problem, it could skyrocket the budget, and we're paying salaries of $100,000, $200,000 to the supervisors and all that, and everybody's like, yeah. And so I just want to caution people. I think Senator Dibble is prescient in this, and I don't believe that the rank and file members of any of the imperative groups want to be put at such a disadvantage that they can't handle it. So
thank you.
Thank you. I'll stop, but I thank you very much. And
I
say this as a friend to all the parties.
There's history in that. Senator Mohamed.
Thank you, Mr. Chair. I have a question for you, Senator Dibble, or maybe others. Do we know how many facilities have had a change in ownership from nonprofit to for-profit in the last decade?
Senator Schomburg, Senator Parry, Kyle. Ladies and gentlemen, the Department of Human Services have an answer to that they could share with FAST? Is somebody shaking their head back there?
Chair Hoffman.
Yes, Schomburg.
Schomburg, I work with Elder Justice Center. Senator Mohamed, we don't know the full amount. A recent inquiry at MDH showed that since assisted living began licensure in 2021, there have been about 200 change of ownerships up until around this time.
Okay.
Senator Mohamed.
Thank you, Mr. Chair. And then for you, maybe Sean, you can help me answer this question. When these sort of changes happen and these nonprofits are bought up by these private equity firms, who often benefits?
Schomburg.
Mr. Chair, Senator Mohamed, the investors that Senator Maye Quade was talking about. What the bill is really trying to do is to disincentivize, disincentivize the stripping of assets from facilities. And that is a very common tactic of what are now called private equity, although I suspect we will see that term shift and morph and change over time, which is why the bill changes the term from private equity to for-profit, because what this bill is really trying to do is get at the actions to make sure that the actions that strip assets and give to a variety of investors, oftentimes we don't even know who they are, is controlled. And as Senator Abeler said, there's guardrails there, and that the true beneficiaries are either the private pay individuals in assisted living. They're no longer seeing their costs skyrocket from 10, 12, 15 grand a month, to the taxpayers who are paying for public pay individuals in either those facilities or in nursing homes.
Thank you, Sean. Mr. Chair.
I think, did you want to respond to that, Ms. Hubert, or do you want to wait till she asks the second question on top of that? What are you thinking?
Thank you, Mr. Chair, Senator Mohamed. Just a very brief follow-up. I do think it would be important to get data from the health department because a change of ownership doesn't necessarily mean it's changing ownership type from nonprofit to for-profit. It means it's changing the owner. And so I would just want to make sure we have the right information from the
And we
health
ran into
department.
that with the Coon Rapids thing 5 years ago, if I remember right. So Senator Mohamed.
Thank you, Mr. Chair, and thank you. That's really helpful. So I've only been in this committee for this session, and I think over the last few months, we've been sort of talking about private equity firms and sort of their takeover around nursing homes and these facilities. And I've been reading this research with the National Bureau of Economic Research, where they sort of talk about how private equity firms, and when they buy up these facilities, the harms that can happen to a lot of these patients. Last week, Senator Mann presented her bill, which was around rates, and not stopping them from raising rates, but saying, we want you to be transparent when you increase rates. And the answer to that was, you're doing rent control. In this instance, Senator Dibble is presenting this bill, and we've got a letter from, I think, one of his constituents and the issues that have had happened to her. I think in this committee, it's about time we take action. Because if most nursing homes, to my understanding, are funded by Medicaid and Medicare dollars. I think we have an obligation to make sure that public dollar is in good use and it isn't just enriching wealthy investors, that it is actually helping people and it's going to what it's supposed to go to, which is care for our most vulnerable communities. Thank you.
I think that's what we do here. I appreciate reminding us, Senator Mohamed, what our purpose and why, right? No matter how we get there. Senator Utke, you get the final word, and then I think Senator Dibble, sounds like I'm glad to hear what you're going to do. I think I've been told this thing because of the A1 amendment took out a section. You do not have to go in front of judiciary, which is a dream come true. Okay, I'm going to get in trouble for saying that. God dang it. It'll be to commerce. So Senator Utke, you get final thoughts before we send this thing on its way.
Thank you, Mr. Chair. And Senator Dibble just got a free pass on that one because that's a breath of fresh air. But anyhow, back to the bill, and we've had lots of conversations, so I won't repeat any of those. But I fully understand where Senator Dibble's coming from. He's representing his district, and we all appreciate that. I'm just concerned about the effect that we're placing on the whole state when we make such a move as this bill is proposing. I do have concerns. And, we've been hearing a lot of different things. The numbers don't seem to be moving much in the last 11 years. I think this is a lot about probably not much or not a lot about nothing, so to speak. Unfortunately, there isn't any money in long-term care. They're all struggling. I don't care the for-profit or not-for-profit structure. Nobody is making big dollars, and in most cases they're trying to survive. And the more of this type of regulation and the requirements that come within basically controls the sales for these people that are still operating it. And we've got a lot of individual operators yet. Those numbers kind of dwindle because it's harder and harder every day to do this. We're basically telling them at this point their property really, it's decreasing in value because of the strings attached. And I don't think we should be doing that because we care about the care that's provided. That's the main thing that we focus on. And they are so heavily regulated from the number of staff versus the number of residents and all these things that come into play. There's not a lot of wiggle room for them. So that's my concern. It's more regulation. And I don't think it's doing us any good. It'll just make it, I think, a lot harder to continue to operate. And when the time comes to transition to a no owner, we don't want to hinder that. We should hopefully embrace it. Yeah, are there a few bad apples? Possibly. But in the end, a breath of fresh air in some of these places is usually a good move. But but I fully understand where Senator Dibble's coming from. He's got a couple challenges back in his district, and he's doing his job. He's looking out after him, so thank you.
I love it. I mean, this is good. Senator Dibble, final thoughts, and then Senator Fateh is going to move that your Senate File 2896 as amended be passed and referred to Commerce.
So, Mr. Chair, I appreciate that I'm appreciated and that I'm recognized for standing up for my constituents, but I don't think that's the purpose that I took this issue and this bill on entirely. That is my entry point, to be sure. But as I've looked into this matter, it is occurring in all of our districts. In fact, I'm standing up for the small skilled nursing facilities and the large ones and the assisted living facilities in all of our districts, because the way people are treated is unacceptable wherever this happens. And there is, and the phenomenon of driving up costs, stripping assets, and ultimately might lead to closure, because we've seen that occur where we have the self-dealing, the ownership is separated from the operations, and then they start paying each other, and the money comes out. So I'm standing up for my constituents, but I'm standing up for everyone's constituents in the entire state of Minnesota. Thank you, Mr. Chairman.
You know what? And this is great. We have the chair of transportation who's deeply embedded for years in the conversation of our elderly services and our elder care in Minnesota. And I'm grateful. Whenever you want to join our committee, you sure can, anytime. Senator Fateh moves that Senate File 2972 as amended be passed and referred to Commerce. All those in favor say aye. Aye. Opposed, same sign. It passes. You're on your way, and you're coming back here to give us an update.
All right.
Did he yield?
Good job. Good luck. Thank you. How do you fix it?
Senator Abeler, I think we're going to have a Senator Fateh bill first.
What?
Yes. You've been
I
bumped.
can read the list.
Senator
Fine. What? Can I sit by him for his bill? I'm going to sit right here.
So
support him in his bill. It's a good bill, Mr. Chair.
Okay, up next, we have Senate File 2732, a Senator Fateh bill. Senator Fateh, I'm trying to see, doesn't look like we have any amendments on the bill. Is that correct, Senator Fateh?
Not unless Senator Abeler has one.
Good.
So Senator Fateh, welcome to the committee. Please present your bill, and I would also ask that the testifiers make their way to the table.
Thank you. Thank you so much, members of the committee, and my co-testifier, Senator Abeler, who just left. I'm here today to present SF 2732. This bill provides an appropriation to the Commissioner of Human Services for a grant to Twin Cities Recovery Project and a respective recovery community organization working on the front lines of Minnesota's addiction and mental health crisis. This is a proposal that addresses a critical gap in our state's continuum of care for individuals in recovery from substance use disorders. Substance use disorders and co-occurring mental health needs continue to take a profound toll on Minnesotans, especially in East African, Black, Indigenous, and immigrant communities in the Twin Cities metro. Despite high rates of overdose and relapse, we know that culturally specific peer recovery services dramatically improve outcomes, yet far too many individuals complete treatment only to face a lack of ongoing support, gaps this legislation aims to close. This grant will allow TCRP to expand culturally and geographically tailored services, including peer support, education, and connection to community, resources proven to reduce disparities in recovery outcomes. This is a modest but meaningful investment that supports safer, healthier communities while reducing long-term costs related to incarceration, emergency care, and hospitalizations. I respectfully ask for your support and look forward from hearing from those providing and receiving these essential services. And with that, Mr. Chair, I'll pass it off to the testifiers.
Thank you, Senator Fateh. Welcome to the committee. Please state your name for the record and proceed with your testimony.
Good afternoon. My name is Latricia Tate.
I am the CEO and co-founder of Twin Cities Recovery Project, a recovery community organization that provides services to the African-American individuals who suffer from substance use disorder. Twin Cities Recovery Project was founded in November of 2016, providing a safe and stigma-free space for those in recovery and those seeking a lifestyle in recovery. In this space, we provided different programs such as dance, games, domino space, all of those things for a person in recovery. In 2018, we decided to add programs to our organization by bringing peer recovery specialists, grief and trauma outreach, men's recovery support groups. We have a young people in recovery program, reentry program, and that's just to name a few of the programs that Twin Cities Recovery Project offers. So we're here today to ask you, the state, for your support in our efforts to expand our reach further into the community, enhance the programs that we currently have, and to bring on additional peer recovery specialists. In our community, the need for peer recovery specialists is becoming greater and greater every day. And so we're asking you to support us in our efforts to meet this demand. And I thank you for allowing us this opportunity to testify.
Thank you. Please, welcome to the committee. Please state your name for the record and proceed with your testimony.
Hi, my name is Cynthia Elmore. I'm a certified peer recovery specialist, and I'm also the grief and trauma program coordinator at Twin Cities Recovery Project. I just come to ask for your support because without Twin Cities Recovery Project, I can guarantee you that I would be either in prison or dead. I've been a part of Twin Cities Recovery Project since 2019. I can tell you this is the first time in my whole life, 5 years straight, I have not been incarcerated. I'm sorry, but if it wasn't for Twin Cities Recovery Project, I would be back in jail and still on drugs. And now I'm working with a lot of my friends who I've been in prison with who's trying to get their life together. And I get emotional because I never had that chance before. I never had nobody to come to support me and say, give yourself a chance and change your life. And I want that for all my friends who've been in and out of prison and who's trying to get off drugs right now. It's a touchy subject for me because I grew up in a real bad environment. I grew up here in Minnesota, but the household that I grew up in was very toxic and very dysfunctional. I come to you and stand here before you now. I haven't been to jail since 1918, and it's 2025, and I'm so proud. And it would help taxpayers not to have to spend money for people to go to jail all the time if we get this support, because there's a lot of people who want to change their life, but they don't know how. And we teach them how. I teach them how. And that's all I want to say. I'm sorry.
Thank you, Ms. Elmore, for sharing your story, and congratulations as well. Thank you for sharing your story with us. Member discussion or questions to the bill? Senator Uckey.
Thank you, Mr. Chair. And I guess a question about the Twin Cities recovery, just a little bit. We're hearing about different things you're doing and stuff. What is your annual budget? I mean, what are you? How big are you, or what do you all have going on? You mentioned, different things, and then this would allow you to expand and enhance some programs. Can you elaborate just a little bit?
Ms.
Yes.
Tate, do you want to take that question?
Yes.
Ms.
Thank
Tate.
you. So we have an annual budget of about 1.5 million at this point. We operate off of grants. We have 3 locations, 3400 East Lake Street. We have 1011 Broadway, and we also have a partnership with Minneapolis Fire, and so we have a space in the fire department. And so one of the things we really would love to, this money would help us with, is expanding our youth program. So we offer a youth program for young people in recovery, and it would be just a great deal for us to have other recovery specialists to support the youth and doing the things that they want to do in the community and teaching them how to live sober. We also have a men's recovery support group that needs some more services added to that. And we're also trying to start a women's support group. So just trying to expand our services into the community.
Senator Recchi, any follow-up?
Yep, thank you, Mr. Chair, and thank you for that. We get to learn a little bit more about what you do. The last question I have, and this might be for Senator Fateh as the author, but just we get to the last line of the bill, and it's support for high-need populations. Just looking for the definition of that, because I don't know that that falls into anything that we have that gives us an exact definition. I understand the people you're serving, they're coming with needs, but it's just a unique way of putting it. Can you elaborate a little bit?
Senator Fateh.
Yes, it's the populations that that was discussed or that was said in the earlier testimony, but if there needs a council definition, I could look to council for that as well.
Senator Recchi.
Thank you, Mr. Chair. Thank you, Senator Fateh. That's all.
Awesome. Thank you.
Seeing no further member discussion, Senator Fateh, any closing remarks before we lay the bill over?
Yeah, thank you so much, members of the committee and Mr. Chair, for hearing this bill. This is a group that's doing really meaningful, impactful work here, and I look forward to earning your support.
Thank you, Senator Fateh. With that, Senate File 2732 is laid over for possible inclusion in the omnibus bill.
What does that mean?
Senator Abeler, I think you're up next.
Okay.
Stay. Oh, yeah. Sit on both the chair. You got to go campaign.
Senator Abeler, we have Senate File 2297 before the committee. That's my understanding. You have a author's amendment?
And I also have an announcement. I'd like to announce I'm not running for the mayor of Minneapolis, just to make sure people, there's been some speculation, but no, I'm not going to do that. So, thank you, Mr. Chair. I have the, sadly, where Senator Hoffman went, I was going to comment that in 2023, this program was changed, and so I can disavow all blame. So we're just trying to pick up the pieces, and unfortunately, the base bill cost too much money. In an effort to try to help good people survive and serve human beings, we've shrunk it down to the A1 amendment, which I would move at this time.
Thank you, Senator Abeler. Senator Abeler moves the A1 amendment as an author's amendment. All those in favor say aye.
Aye.
All those opposed say no. The motion prevails and the A1 amendment is adopted. Senator Abeler,
Thank
to
you,
your
Mr.
bill
Chair.
as
We're on a
amended.
roll. We're running late, so I'm just going to defer to my extremely capable testifiers.
Ms. Grafstrom, welcome back to the committee. Please state your name for the record and proceed with your testimony.
Good afternoon, Mr. Chair and committee members. For the record, my name is Sarah Grafstrom, Senior Director of State and Federal Policy at ARM. Thank you for the opportunity to testify on behalf of Adult Family Foster Care Services in Minnesota, often referred to as Family Residential Services or FRS. This is a care option in which someone can choose to live with the family providing their services. The FRS provider is licensed under 245D and must follow the same licensing regulations as a corporate service provider. During the 2023 legislative session, new flat rate tiers for the adult family care, foster care, and life sharing services were passed and will be effective January 1, 2026. These services, which were previously funded through the disability waiver rate system, will now be moved to a flat rate with no option for rate exception. As our FRS members look at the proposed tiers, they are reporting a reduction of up to 65%. That severe reduction has the overwhelming majority of providers unsure if they will be able to continue to provide services. With the new rates set to take effect in just 9 months, we are asking the legislature to step in and provide a lifeline. Senate File 2297 proposes a delay to the rate tiers and a task force to develop alternative payment models. Understanding the limitations, however, that the legislature is under this session when it comes to cost, our Delete Everything amendment will lower the cost while still helping FRS homes stay afloat during this time. By creating a one-time funding mechanism for FRS homes at risk of closure, we can help maintain the over 1,100 homes in Minnesota while working toward a better solution when the budget environment is not so restrictive. We are proposing creating an emergency fund of $1 million each year for the next 2 years dedicated to FRS homes at risk of closing their doors. While this is not a final solution, we believe this stopgap will support providers and those they care for from effectively finding themselves out of work and the individuals they support without a place to live. Many FRS homes have supported the same individuals for over 30 years, and yes, this is a setting where they receive care, but it is also their home and their family. The greatest risk right now is to do nothing, to keep the status quo and implement flat rates in 2026 without an additional funding mechanism to keep providers afloat. At a time of staffing shortages, massive proposed budget cuts at the state level, and even more uncertainty with Medicaid, this would be a dangerous thing to do. Now more than ever is the time to ensure that all services are sustainable going forward, especially ones as cost-effective as adult family foster care services. Thank you for the consideration and the opportunity to speak on behalf of FRS homes across Minnesota.
Ms. Olson, welcome to the committee. Please state your name for the record and proceed with your testimony.
Thank you. My name is Alicia Olson. I'd like to thank you for this opportunity to testify on behalf of Senate File 2297. As I've said, my name is Alicia Olson, and I am an adult family foster care provider in Zimmerman, Minnesota. While I have been providing care in my home for the last 5 years, I've actually been in the field for the last 17 years as I was a supervisor at a CRS prior. My experience enables me to know both the similarities and the differences that are in both settings, running each type of home as well as the services offered to each residence. Each setting is similar in its structure, yet very different in its approach. That approach can often mean the difference between someone merely surviving and someone thriving in an environment that better suits them. Minnesota has been on the right track by offering choices that clients get to make when it comes to their housing. As changes are being made to how the FRS is done, like now reducing our beds from 4 down to 2 and removing us from the DWRS coming January 1st of next year, this wonderful choice is at risk. We are begging for a seat at the table to get rates that are livable to prevent mass closures across the state. As providers, it's difficult to imagine having to look at our clients in the eyes, the ones who have grown to become like family and lived in our home for years, sometimes decades, and tell them that we have to close because we can't survive off of less than minimum wage. And to Senator Hoffman's point about PCA pay 12 years ago, if you look at the proposed rates, we will be falling right at that hourly rate with the proposed tiers. They have chosen a family atmosphere, and now their choice no longer matters because a budget change makes it unavailable to them. We are in desperate need of support, even if it's a stopgap solution before a long-term fix can be made. Think about your day-to-day family events and costs. Every little thing has a price associated with it, and we are the head of the household. So as FRS providers, we are paying for far more than your standard operating costs to maintain that family atmosphere that they want and need. Life-improving things like partaking in sports, activities outside of the home, vacation, proper meals, and things like going out to see a movie. Those are those little things that create those family memories, and rarely are they free. We are begging for a chance to explain what we do and why it's a critical part of the ecosystem of the disability care that we have here in Minnesota. We aren't just sleeping in our own beds or hanging out. We're on suicide watch, changing briefs, helping with all ADLs, while staying 10 steps ahead to prevent behaviors or medical emergencies, many times when we are on our own vacations. Our cuts set to start on 1/26 are based off a min-choice assessment that is not holistic and have been delayed, so no one could even give us a formal answer as to what tier our clients fall under. But regardless, they don't allow us to even pay our supplemental staff minimum wage. So help us prevent unneeded chaos to not let potentially 1,000 of adults living with disabilities become unhoused. We can help now by setting up a fund to help homes across the state from closing, and we can keep pushing for a better solution for the long term. We want to keep working, and we want to keep serving in Minnesota's most vulnerable populations. Please help us do that. Thank you.
Member discussion or questions? Any closing comments, Senator Abeler, before we move the bill to state and local government?
Actually, you don't need it anymore. We just did a delete all for money, so there's no task force anymore.
Okay.
So this is what happens, Mr. Chair, and I wish Senator Hoffman were still here. There's 2,500 people nominally involved in this in a very nice, attractive setting. In the time when we had $18 billion to spend, there was a decision made to reduce spending in this area as some kind of a reform. The effect of the reform could have been useful if it could have been done more carefully done with some more targeted work, but this is actually done with a chainsaw, in my opinion anyway, and it's an unintended consequence. 2,500 people, and we're asking individuals that serve, some of them to work for $7 an hour, which, and it's just a problem. And so we are spending a good deal of time worried about Medicaid cuts at the federal level, the governor's budget here, a deficit. This was an unforced, in my opinion, error done in 2023 when there was buckets of money running around. And the consequences are now delayed and are in the middle of a time when there's simply much less resources. The stopgap fix that the amendment brings is simply a way to stave off the harm and the soft land as best can be some of these individuals while having really no good long-term answer. And so I'm afraid that this will be the, if we, I guess we're, which I don't even know what to tell you. So the other bill, the original bill is much better. We just can't imagine there's any kind of money like that to make this right. There should have been a more thoughtful process. And again, the people here from DHS have no ill intent in any of this. They're merely messengers. But the consequences of what happens from these decisions that they are provoked to implement on behalf of the governor are just really harmful. And I don't know what's going to happen to these 2,500 people. And I appreciate the testifiers today. So with that, Mr. Chair, we'll lay it over. And it's just too bad that, Mr. Prayer, that prayer has to be a strategy for some of these people, because I think if you talk to the people serving them and the families and the people themselves, this has nothing to do with deficits now. It has nothing to do with any federal changes. It has to do with some decisions that were made by people who somewhere should have known better. So anyway, thank you, Mr. Chair. And with that, we can lay it over.
Thank you, Senator Abeler. Senate File 2297 is laid over for possible inclusion in the omnibus bill. Next up, we have another Senator Abeler bill, Senate File 2202. Senator Abeler, to your bill.
Well, thank you, Mr. Chair. And just on a different note, we're going to play Name That Tune. Starts with 48. And anyway, this is, Ms. Abderholden has, this is, I think, a version that's perhaps closer to the report of the task force and to the best ability of Ms. Abderholden. And we are faced with so many challenges, Mr. Chair, in so many ways. And now we're going to talk about corrections and people with need for mental health care. And so the hour is getting along, and so I just told Ms. Abderholden she can comment however she wants. I don't think we need a very long discussion on the topic, although I'm going to summarize at the end, and I thank you for the time.
Ms. Abderholden, welcome back to the committee. Please state your name for the record and proceed with your testimony.
Thank you, Mr. Chairman. Members, Sue Abderholden, Executive Director of NAMI, Minnesota. This is a really difficult policy issue. We don't want people with serious mental illnesses languishing in jail. We don't want people with serious mental illnesses being in an inpatient unit for over a year and taking other beds offline. We don't want people at AMRTC who are ready to move to a less restrictive setting sitting there on waiting lists. We want people to access the right care at the right time at the right place. It's important to understand a couple of things. One is that the number of people deemed incompetent to stand trial has increased significantly over the last 10 years since the 48-hour law went into effect, and not just in Minnesota, but across the country. This led the legislature to first establish the Competency Restoration Task Force in 2019, which met for 2 years and passed landmark legislation to begin to address this issue and stop the revolving door to the jail by connecting people to services. It also led the legislature to establish the Priority Admissions Task Force, which met for essentially 2 years. So this group of people have been meeting for some time to discuss this issue. Last year, after the first set of recommendations were released, in February, Representative Edelson gathered everyone together, MAXA, county attorneys, sheriffs, community providers, hospitals, advocates, and DCT to write the bill. We spent many hours in room 500 North. I just want it noted for the record that NAMI did not write the bill. We all did over several long weeks. This year, NAMI did take the initiative to take the recommendations and draft the bill that is before you. I did prepare a chart for you comparing the county bill and this bill and the recommendations so that you can see how we were trying to line things up. I just want to say that if you think by simply adding more state hospital beds that that's the sole answer, you're wrong. That's why the Priority Admissions Task Force and then the panel have a range of recommendations to address this problem, including focusing on diversion, early intervention, engagement services, community services, locked IRTs, and yes, some additional state-operated beds. I want to say that agreeing to the recommendations in the report was not easy. It was actually pretty much the final hour of the committee, and so I would urge you to really adopt the recommendations in the report. The panel recommended that we continue our work to monitor progress and for transparency. They recommended that we keep the current 48-hour law that is tied to using the priority admissions criteria and that the 48 hours kicks in when there is a medically appropriate bed. We've heard that keeping the 48-hour law, the original one, will hold DCT accountable, but they cannot magically come up with beds. It's the legislature that decides how much money goes to expanding DCT and community services. So why have a timeline that can never, ever be met? The panel also recommended providing basic mental health care in jails, increasing community capacity, providing a public dashboard, continuing the DNMC relief to counties, and allowing 10 people to be admitted from community hospitals. Everyone really has a responsibility to address this problem. Counties do have a responsibility as the local mental health authority. Hospitals and community providers do have a responsibility to expand their services to try to meet people's needs early in the community. Using our crisis teams instead of police will prevent more people from entering the criminal justice system. Ensuring that basic mental health services are provided in the jail will prevent people from deteriorating. And yes, having more intensive and secure settings for people who need them. Again, please follow the recommendations in the report. That's why we have legislatively directed task forces. Thank you, and I'd be happy to answer any questions.
Thanks, Ms. Aberholden. I also have 2 additional testifiers signed up if they still wish to testify. So if they can make their way to the table.
There you go. You're here to help.
And we'll start off with the Minnesota Association of Community Mental Health Programs. Welcome to the committee. Please state your name for the record and proceed with your testimony.
Thank you, Mr. Chair. Thank you, members. My name is Jinlee Palin with the Minnesota Association of Community Mental Health Programs, and I am here today in support of Senate File 2902. I'm also here today to let you know that I am testifying as a member of the Priority Admissions Task Force. My association was one of the associations or groups listed in the legislation that initiated and implemented the task force, and I've been serving on the task force along with Ms. Aberholden and several other community partners since 2023. I'm here to affirm, or rather confirm, the agreement that the task force came to for both the final recommendations in the 2024 report as well as the 2025 report. I'm also here to note that I was part of those large community partner groups that were involved in drafting and negotiating the bill in 2024 that Representative Edelson pulled together. We were in the state office building many times over the course of last session, working through several different negotiations to come to the bill that was moving forward through last year, as well as coming back in the fall to work together as the task force or the priority admissions panel. I'm here specifically to emphasize some of the recommendations, both in the report and the proposals in Senate File 2902. They're very similar to what Ms. Aberholden already listed, but just to offer a little bit more support from the community provider perspective. We absolutely support the funding of the additional 50-bed addition to AMRTC, as well as funding for the staff to provide the services in the facilities. We absolutely support the increased reimbursement rates proposal for Medicaid outpatient services in Senate File 1402 currently this session, increasing the funding for mobile crisis teams, Senate File 1599, increasing the funding for first episode psychosis programs and first episode bipolar disorder programs. Those proposals are being carried in Senate File 1953, and also to lend our support to the extension of the 48-hour rule sunset so that they do have 48 hours when there's a medically appropriate bed available for the next 2 years, and to renew the exception of admitting 10 additional hospital patients to DCT when there are beds available. We really appreciate the committee's support and commitment and the legislature's to increase access to our mental health system, and we hope to work with you all moving forward. Thank you.
Welcome to the committee. Please state your name for the record and proceed with your testimony.
Thank you, Mr. Chair, members. My name is Danny Ackert with the Minnesota Hospital Association. MHA supports multiple provisions in Senate File 2902 representing recommendations from the Priority Admissions Task Force. We have submitted a letter offering more detail for your consideration. I want to bring your attention specifically to Section 6 of the bill, which extends the limited exception to add up to 10 civilly committed community hospital patients per fiscal year to the wait list for medically appropriate admissions to direct care and treatment. MHA strongly supports this provision, and we're grateful for the chair amending his bill on Monday with that provision as well. Civilly committed patients in community hospitals awaiting admission to DCT often require unsustainable attention and one-to-one care, often with strict security measures, security and safety measures best suited for DCT and state-operated treatment facilities. Such situations are becoming far more common and forcing hospitals to close units, to keep care teams, other patients, and the public safe, further limiting access to already strained hospital beds in high demand. Based on the figure you will find in our letter from a recent DHS report, this trend unfortunately comes at a time when admissions to DCT from community hospitals are at an all-time low. So extending the 10 patient exception not only will allow civilly committed patients to be treated and cared for better, but will free up more access at community hospitals, keep care teams safe, and begin to address the ever-mounting number of avoidable days in community hospitals. We also urge this committee and the legislature to recognize that capacity at DCT is needed and that ongoing and dedicated funding for capital and workforce is necessary to make sure that all care that's needed at DCT can be delivered. I want to thank Senator Abeler for making that point multiple times on this bill in discussion, that it's not just the capital and the space, but it's also the highly educated and highly skilled workforce needed to deliver this care. And so we look forward to working with Senator Abeler in this committee to move this bill forward and make sure that all patients, especially civilly committed patients, get the care they need when and where they need it. Thank you.
Thank you. I had a couple of questions. As I was looking through the bill, and I want to make sure I'm not missing it anywhere, I don't see any capacity increases at AMRTC or any other facilities in direct care and treatment. I just want to make sure I'm not missing that. So I don't know, Ms. Abderholden, is there any capacity increases in this bill?
Mr. Chairman, members, yes, it's just that it's in a different bill number. So it is Senate File 2901. It would go to bonding to make that first step to creating that additional 50 beds.
Thank you, Ms. Abderholden. And as a follow-up question, as a part of the Priority Admissions Task Force report, as a part of extending the kind of modified 48-hour rule, whatever we want to call it, for the medically appropriate beds, was the agreement from the task force, was that conditional on additional capacity? Just want to make sure I'm understanding what the task force came back with. Ms. Abderholden.
Mr. Chairman, yes, but it was also looking at what some of the other capacity could be. So if, for example, we had a locked earth facility develop in the metro area, or anywhere else in the state, that could actually expand capacity from people who are waiting in jails. But we also know that in order to expand the capacity right now at DCT, we need another building, and that's not going to happen overnight. And so I think progress is partly moving forward with the bonding section. So either we're, getting the plans ready to build them new ones, or I know Senator Abeler is looking at, can we, modify Miller in some way to add some more beds there as well. And there were a couple of other things that have also started that we don't know the outcomes yet. For example, the volunteer engagement piece that should be starting in your district, right? And the RFP was issued this week. That could actually prevent lots of people from ending up in jail in the first place.
Thank you, Ms. Abderholden. And I'll just, before I see if any other members have questions, I just want to say appreciate Senator Abeler and his work on this topic, Ms. Abderholden, and everyone else who's been involved in these conversations. I think it's an important topic, something that we have to address urgently this session. Something has to happen this session, and I guess my encouragement is that we have to work together as advocates who see a problem in this area to try to improve capacity, because I worry if we don't do something this session, the budget year, I don't know when we'll ever be able to add capacity. So that's just some of my comments, so.
Mr. Chairman, if I might.
Ms. Abeler, yes. Yeah.
I just want to say that we've also, on the House side, now have a meeting on Tuesday with both Representative Frederick and Representative Nadeau and all of the kind of parties to start looking at the language to see where we can actually come to an agreement on.
Great. Thank you, Ms. Abeler, for your work. Any other member comments, discussions? Senator Uckey.
Thank you, Mr. Chair. And just a little clarification for Ms. Aberholden. You, as you were ending your testimony, you mentioned a few different items, and the part that caught me was that hospitals were included in there and have a responsibility to expand services. Are you speaking of DCT or general hospitals across the state?
Ms. Aberholden.
Mr. Chairman, Senator Uckey, I believe they also have community hospitals also should be expanding their beds to meet the needs as well.
Senator Uckey, any follow-up?
Yeah, thank you, Mr. Chair. Expanding their beds to serve for mental health, which would bring in a whole new operation for them. They're not geared for that at all, so they'd be starting from basically scratch.
Ms. Aberholden.
Mr. Chairman, Senator Uckey, I mean, some hospitals already have a psychiatric unit, and so they could, they could possibly look at the adding beds. We know that there's discussion about a new hospital at, Hennepin Health or HCMC as well, a new building. So could they add some beds there as well? So I think it's, when we look at who's responsible for the mental health system, there's a lot of different people that are responsible for trying their best to meet the needs. Some places might actually create more of, we've seen in the past, sometimes hospitals have worked with community providers on IRTS programs so that they can move people along to some place that's safer and better meets their needs as well.
Okay.
Senator Uckey.
Thank you, Mr. Chair. And that helps some because I was thinking hospitals across the board. I think of all the hospitals out in my rural area, but you specifically named some that already do that. You'd ask them to possibly expand or enlarge, but we're not going to ask those that aren't in the business to expand because they can't.
Ms. Aberholden.
Mr. Chairman, Senator Uckey, clearly in workforce in rural areas is a real problem as well. There is an exception to the I'm forgetting the name of the hospital, the type of the hospitals, the critical access, thank you, critical access hospitals. There is an exception to the size of them if they add psychiatric beds. And perhaps there's a way, that we can look at more crisis care in some of those hospitals. I just think that when we think about, again, the grand scope of services, by the time someone gets into jail and has a very serious mental illness, somewhere we've missed them along the way and haven't helped them, right, when they needed it. And that's why we think about it as a front door and a back door issue. When we look even at DCT and the jails, what did we do beforehand to prevent that from happening?
Thank you, Mr. Chair.
Thank you, Senator Uckey. Any further member discussions or questions? Senator Abeler, any closing comments? I think the motion here is going to be to send this bill to State and Local Government Committee.
Oh, it is? Sure. Send it wherever you want. There's much more discussion to be had, and understanding the math we're in, I don't know how any of the bills we've heard become operational in a very strong way, and I share your concern that we need to do something. So I think fleshing this all out is useful. There are task forces that meet and then they're done and nobody cares. This is a task force that actually came to some consensus across relatively divergent groups with many interests. And I think the core of the agreement is stable and useful, and so that there's something to build off of that. And whoever decides, if you have some money, at least you'd go from the right catalog and buy one of these, and let's buy that one, and at least you're buying the right things whenever you go to buy them. And so I think that, as was commented by Senator Janelle Ellison and hospital people that, and everybody, that you need staff. You get a building, here's your 50 unit building, and where are you going to find people to operate it and be the correct people? How are you going to pay for that? If you have a 16, there's some federal help from that, which maybe still would be coming. And so I think it's going to require a lot of creativity, but I like the agreements that have come on here on this really provocative question. We've created an entitlement to individuals, now deferred a bit to serve them. Can indeed some of these older buildings be used for a purpose to help divert some of these individuals? Can Miller be made to function? Can the beds up at Cambridge, the 32 or whatever twin home, there's 16 twin homes up there, could they be used to be something? Since we're running a little low on bonding money. So finally, Mr. Chair and members, this session, at the very least, we're going to have to decide what's on the table. What's on the table in front of us? The governor says charge the counties more money and do nothing and extend the 2 years. And those are kind of the choices that we have before us. Shall we leave the counties paying the same? Shall we charge them more? And instead of putting the money into the general fund, create a fund where they would all chip in toward creating a better thing, because they're going to be paying anyway, and property taxes and so on if this all goes the way it is. And should we decide that one decision we have to make for sure in this committee, do you leave it the 48-hour rule and you let the 2-year extension go away and go back to 48 hours, which we know we can't sustain, or you put it off 2 years to let the system muddle through again? So I appreciate the discussion. I appreciate the depth of knowledge of this committee. So thank you, Mr. Chair. And with that, I'll move to send it to wherever you said, state government.
Senator Abeler moves that Senate File 2902 be recommended to pass and re-referred to the State and Local Government Committee. All those in favor say aye.
Aye.
All those opposed say no. The motion prevails, and Senate File 2902 is recommended to pass and re-referred to the State and Local Government Committee.
Thank you.
Senator Rasmusson. Senate File 626 is before the committee. Senator Rasmusson, to your bill.
Thank you, Madam Chair. And what we're doing here today is essentially an update on this bill. As members might recall, this bill would change direct care and treatment back to a more traditional commissioner model. Right now, in current law, on July 1, direct care and treatment is slated to have this part-time board that would be the governing body and ultimately responsible for direct care and treatment. And this committee has discussed this proposal before. It went to the State Government Committee where a major amendment was adopted, and so Chair Hoffman just wanted to make sure that members were brought up to speed on key changes made in the bill. And I just wanted to express gratitude to the skeptics of this idea in terms of offering questions and feedback, and much of that is incorporated into the bill before the committee. I will just highlight a couple of the meaningful changes in the bill that we did receive extensive technical support from direct care and treatment and also MMB that's been incorporated. One of the major changes that was made in the State Government Committee is that we will now be retaining the direct care and treatment CEO, who will serve as the chief medical officer, the individual who's administering and running the healthcare side of direct care and treatment. And we would specify that that CEO would report up to the direct care and treatment commissioner. We have added language that has qualifications for the direct care and treatment CEO, that they must be selected without regard to political affiliation and have experience that is relevant to operating a large healthcare service and delivery organization like direct care and treatment. So that is one of the major changes that has been made. We also, at Senator Hoffman's request, added an additional member to the advisory council from the Minnesota Disability Law Center. And then I'm trying to go through. We've also clarified the role of the CEO and specified that they will effectively serve as a deputy commissioner reporting up to the commissioner. Those are the major changes. The rest are largely technical, but happy to take any questions from members.
Members, any questions? Okay, Senator Rasmusson, I will say thank you for your work on this and taking a lot of feedback on it. I will just state again for the record, because I think it's important, that my worry always moving from what is currently in law to what is being proposed here is that it politicizes the work of direct care and treatment, which is very easily able to be politicized, right? The folks that are, we are their healthcare provider, unlike every other place. It is some of, I think direct care and treatment refers to people who can't or won't be treated anywhere else. And so it's easy to politicize the folks who receive that care. And so I think that as we move forward, it's something we'll keep our eye on, because if we do end up in a place where we're seeing the politicization of the people in DCT and the care that they need or are receiving politicized, it might warrant relooking at this. But I think your points, some of them were well taken as well, right? I mean, it's a budget area. It should have a commissioner to oversee it, and one that is accountable to the governor. So I appreciate your work on this and bringing around a skeptic who will carry like 15% of my skepticism forward with this bill, but not so uncomfortable that I can't support it. So I appreciate that. Any other member questions or comments? Okay. Senator Rasmusson, this is going to be laid over for possible inclusion in the omnibus bill. Senate File 626 is laid over.
Thank you.
Thank you. No. Senator Rasmusson, would you like to make closing comments?
Sure, Madam Chair, and I appreciate that that concern, right? And having an important agency making overtly political decisions, I think, is a concern. And I think with the model here, where we have a politically independent CEO who's running the day-to-day operations of direct care and treatment, will provide that insulation, while also having a commissioner who can do the important public policy work of working with and convening groups to work on the 48-hour rule, or working with the counties on various issues that they're facing, trying to advocate for a budget for direct care and treatment, and some of that other important policy work that has. And so my hope is that this strikes a proper balance to make sure that we're serving the people that direct care and treatment serves, about 12,000 clients every year, the 5,000 employees who work there, and the many Minnesotans who depend on direct care and treatment to do their job well. And so appreciate the continued conversation, Madam Chair.
Thank you, Senator Rasmusson. I'm so sorry. I do have a question. Because we're adding a position, does this add cost?
Thank you, Madam Chair.
Yeah.
There is a fiscal note has been requested for this bill. I don't know if it's yet prepared, but we anticipate that there'll be a fiscal note. But I would just say, in the grand scheme of things, direct care and treatment is a 5,000 employee agency, more than $1 billion. And so I think making sure we have that governance structure is worth the investment.
Thank you, Senator Rasmusson. All right, and with that, Senate File 626 is laid over for possible inclusion in omnibus bill.
Thank you, Madam Chair, and thank you. I think let's go to Senator Mohamed, right? Is she here? There she is. You want to do both yours, Senator? Senate File 2805 and 2733? Yes. Senator Mohamed, 2805. No. Senate File 2805. Opioids, substance use, addiction, subcabinet members added provisions, SLG waived. You got Jeremy Drucker from the Minnesota Office of Addiction and Recovery here? Now that we're done with this bill, I want to thank you very much. And, oh, sorry. Director Drucker. So, Senate File 2805 is on the board. Talk to us, Senator.
Thank you, Mr. Chair, and thank you for letting me budge you. Before you is Senate File 2805. The subcabinet on opioid substance use and addiction was created with bipartisan support in the 2022 legislative session. The purpose of this cabinet is to bring together all of the various state agencies that address substance use disorder to improve outcomes for Minnesotans, their families, and their communities. Since the appointment of its director in January 2023, the subcabinet has driven policies and agency action to reduce overdose deaths, improve access to care for incarcerated Minnesotans, expand access to the overdose reversal drug naloxone, and create recovery-friendly workplaces and many other initiatives across state agency jurisdictions. When it was created in 2022, the state government looked different than it does today. DHS was a bigger agency that still contained functions that have moved to the Department of Children and Family, and DCT was also still part of DHS. The Office of Cannabis Management had not yet been created. This bill would update the membership of the Opioids, Substance Use and Addiction Subcabinet to align with the current state government framework. Specifically, the bill adds the Department of Children's, Youth, and Family, direct care and treatment, the Office of Cannabis Management, which are new entities since the subcabinet was formed. It also adds the Department of Commerce, which, as the regulator of the private insurance market, has an important role to play in overseeing substance use as a parity in behavioral health needs. Each agency has been consulted and welcomes the opportunity to join the subcabinet. And with me is Director Jeremy Drucker.
Thank you so much, Senator Mohamed. Mr. Drucker, introduce yourself for the record. Welcome to the committee. You may begin your testimony.
Thank you, Madam Chair, committee members. My name is Jeremy Drucker. I'm the director of the Office of Addiction and Recovery and the State Addiction and Recovery Director. I think what we're trying to do with this bill, as Senator Mohamed said, was really just align the current subcabinet with what the current state government framework is. Many of these agencies that we are discussing are already participating as sort of ex officio members of the subcabinet. I think what we'd like to do is just codify that so that as state government moves on in the future, as new administrations come in or new directors are appointed, we maintain sort of the fidelity of the subcabinet to reflect the current state government framework.
Thank you so much. Member questions? Senator Abeler.
Hey, welcome. I remember when we created this, and I'm glad it's all working out. Can you just give a 30-second snapshot of how it's going? Just really short.
Mr. Drucker.
Thank you, Madam Chair, Senator Abeler. There is a lot of work happening right now across the administration. How's it going? I think we're making a lot of progress in areas, particularly in overdose deaths. We're seeing declines for the first time in several years in overdose deaths. So in 2023, there was about an 8% decrease in overdose deaths. We're projecting for 2024, the Department of Health is, while that data is preliminary, perhaps a 37% decrease in the upcoming year. So really working across state agencies. So like when you think of harm reduction, for example, working with the Department of Human Services, the Department of Health, the Department of Corrections, which has a role in that, to really look at how they are addressing that part of the continuum together, not duplicating efforts, aligning efforts, coordinating. So we focus a lot on sort of those cross-agency partnerships.
It's good enough.
Senator
Thank
Abeler.
you. So.
That's great news to hear. Yeah. Any other member questions? All right. Senator Mohamed, Senate File 2805 is laid over for possible inclusion in a future omnibus bill. And you may stay right there for Senate File 2733. 2733 is before the committee. Senator Mohamed, to your bill.
Thank you, Madam Chair. Before you is Senate File 2733, which proposes a one-time appropriation of $200,000 in fiscal year 2026 to the Niyyah Recovery Initiative, a culturally specific recovery community organization serving immigrant communities and refugee populations here in Minnesota. Niyyah provides a critical service at the intersection of public health and cultural responsiveness. The organization is uniquely positioned to reach individuals impacted by substance use who are often disconnected from traditional recovery systems due to stigma, language barriers, and a lack of culturally relevant support. This appropriation will fund outreach, staffing, programming designed to help individuals in the immigrant community who are ready to take intentional steps toward recovery. It supports an approach that meets people where they are at and provides culturally grounded, peer-led services that restore dignity and purpose. This bill reflects a modest but targeted investment that will yield outsized impact by focusing resources where they will be most effective on individuals ready to grow and rebuild their lives through recovery. And with me is Farhia. Thank you, Madam Chair.
Thank you, Sir Mohamed. Farhia, welcome to the committee. Please introduce yourself for the record. You may begin your testimony.
Thank you, Chair Hoffman and the Senate Committee. My name is Farhia Badul, and I am the founder of Niyyah Recovery Initiative. Niyyah means intention, intentional recovery. And I am a woman in long-term recovery, and what that means to me is that I can first show up for myself, my family, and my community. Recovery has truly given me back my values and my traditions. I founded Niyyah Recovery Initiative because there was a huge gap in the services that were being provided from treatment to recovery. We are doing outreach, awareness, and education. There is a lot of stigma and shame that comes with persons who struggle with the disease of addiction, substance use disorders, and mental health. What we're doing is very significant in our communities. We have limited resources right now, and every day we do this work with heart, grit, and limited resources, and still the demand is growing. People are looking for recovery that reflects who they are, not a cookie-cutter approach, and really understanding that this is a huge investment in our community. So please fund this work to expand it, because everyone deserves a path of healing, and because recovery works and that recovery looks like this today. I am deeply grounded in my faith and my spirituality, and we're really meeting people where they're at, providing that recovery support. One thing that I really want to address is that treatment and recovery are two different things. Treatment is treatment, and recovery is what happens after treatment. So people are not going through the same, when they leave a treatment center, they stay there for 90, 60 days. They come back to the same people, places, and situations. They oftentimes have a relapse or reoccurrence that happens, and then they go back to the same treatment center that just discharged them. What RCOs do, and what Niyyah Recovery and Twin Cities Recovery Project and the work that we're doing is, we're really helping people the minute they come out of a treatment center. We're providing them with the care that they need to either go back to school, get a job, volunteering community, whether they want to go back to the mosque. So this work is really critical, and who knows it better than the people who have lived this through, people like myself and the people that work with me. So thank you.
Thank you. Do you have one more, or we're good? I think there's this one we're going to lay over, right? Any members' questions? Nope. So thank you, Senator Mohamed. Senate File 2733, we're going to be laid over for possible inclusion in the omnibus bill. Does that sound like a winner to you?
Sounds good to me.
Thank you. Next up, I'm going to go ahead. The Senator, who wants the gavel? It's going to do mine, and then we're going to do here.
Thank you.
This one and the other. This one's got to go to the floor.
Okay.
Does that work for you guys?
All right, Senator Hoffman, Senate File 476. And I believe you have an A1 amendment. Hold on.
Unless we're laying this one over. That's okay. No, I think this one we need to go to the floor. Ani Simons is coming up too, Madam Chair.
Yes, Senator Hoffman, Senate File 476 is before the committee. Would you like to adopt the A1?
Yes. Can
Okay.
I please move the A1 amendment?
All right, Senator Hoffman moves the A1 amendment. All those in favor say aye.
Aye.
All those opposed?
That's great. Thank you.
The amendment is adopted. Senator Hoffman.
Thank you. That just tightens everything up, and it narrows the one-time grant program established in Section 9. So members, Madam Chair and members, we share that goal of increased access to home care services that allow older Minnesotans and those with disabilities or complex health care needs to remain living in their homes with their families. We mean home first. I remember that theme. Many of us care about this issue for three reasons: access to home health care, health services is most often the preferred choice of our constituents compared to care in a hospital, nursing home, or other long-term care settings. Access to home health services is a key step in easing the stress on our currently overstressed hospitals and other congregate care facilities. And the third reason is access to home health care saves our state a significant amount of funding as compared to providing this care in an institutional setting. The Minnesota Home Care Association offers the 3 steps the legislature can take to increase the access to the home health services for our constituents. Those include the allowing MA reimbursement for a limited number of required care evaluation visits, then implementing a medical assistance reimbursement rate that increased for a specific set of home care services and establishes a one-time grant program drawing in new home care staff. So I want to thank the bipartisan list of co-authors that have joined me on this important proposal. If Ani Simon wants to come down and talk about it, she sure is on her way. So can I tell you a story about Ani Simons?
Mr. Chair, 30-second one.
There you go. Thank you, Ms. Simons. Huh? It's right. That is correct. We already heard this bill as an agenda. It was laid over, so I think this one we need to be able to just move this to the general orders. So,
Okay, so
I would like to move Senate File 476 be moved and placed on general orders.
all right, Senator Hoffman moves that Senate File 476 be recommended to pass and put on general orders. All those in favor say aye.
Aye.
Aye. All those opposed?
No.
Senate File 476 is on its way to the
Division.
floor.
Thank you, Madam Chair and members. Next up for you, Madam Chair.
It was a controversial bill, Mr. Chair. Okay, Senate File 2031.
No.
Okay, Senate File.
Oh, wait, no, I'll do 2031. Yes, that's correct. Yes. Yeah. My bad.
All right, Senator Hoffman moves Senate File 2031 before the committee. Senator Hoffman, to your bill.
Thank you. This is just an appropriation restoring for all, and it's really it's appropriation of general funds to the Commission of Human Services for a grant to Restoration for All, Inc. The awarded grant money is used for activities designed to enhance the culturally relevant services and resources for Minnesota African immigrant refugee community. The same thing that we talked about for the last couple of years, specifically on the substance use disorder and suicide prevention. And that is something that I do want us to, I think David, where did David go? We're going to bring this one back on Wednesday to lay it over because we're going to do some changes in some language, but I wanted to bring it to everybody's attention. This is something we want to stay within our committee. So is
Okay.
that fair?
Yes, Senate File 2031 is laid on the table.
Thank you, Madam Chair.
All right, Senator Hoffman, Senate File 2876.
Thank you, Madam Chair and members. This legislation supports the integration of the home and community-based services, the HCBS, and healthcare services, and allows for that value-based design that are backed by data. Senators, we have you, Madam Chair, Senator Utke, Gruenhagen, and Abeler on this bill as well, and that really gets to the effective coordination that gets people closest to the individuals in the intellectual developmental disabilities world and mental health conditions that will, 3 things, lead to better quality of life outcomes, result in people being more satisfied with their services, and then that, of course, is a decrease in overall costs. So I think, Madam Chair, we have George Clauser, who is the CEO of Altair and a parent of a child. I've known George for many, many years. George is here. Danielle Fox is the CEO of Mount Olivet Rolling Acres. And then I think Scott, is Scott with us too? Scott Hinchy? Come on up, Scott. So, Madam Chair, with that.
Okay, Mr. Clauser, introduce yourself for the committee. Welcome, and then you may begin your testimony.
Thank you, Madam Chair, and thank you, Senator Hoffman. My name is George Clauser. I am the CEO of the Altair ACO, which is a disability collaborative, also a 25-year advocate for people with disabilities, and I'm testifying today as a parent, a proud parent, I might add, of my 39-year-old daughter with cerebral palsy. Her name is Christina. Christina is partially verbally impaired and experiences a lot of health difficulties. I wanted to share one recently that brings this bill close to home. She developed an infection in her mouth that really created a situation where she couldn't eat because she couldn't communicate with us. We weren't quite sure about what the problem was. We attempted to get an appointment with her Medicaid dentist for an emergency visit. As you may know, there are over 5,000 people on the waiting list for dental appointments in Minnesota. Christina was told that she would have to wait a month for an emergency visit. And in those cases, you are sent to the emergency room. We went to the emergency room only to find out that their dentist on call was not available that evening, and we were sent home with an antibiotic, which we started Christina on, and talked to her case manager to see if she could guide us in a better direction because Christina was getting worse. She started to develop a fever. Her advice was take her back to the emergency room. So, as often happens in these situations, you go back to the emergency room because you have no other alternative in trying to treat the situation. So we went back to the emergency room. By that time, her fever was 103. She was very close, bless you, she was very close to being septic and ended up being in the hospital for approximately 5 days on IVs. Turned out to be an affected molar, and by then the case manager returned our call and said, you have to private pay the dentist because that's the only way you're going to get in, and she is in need of dental care. I share this with you because it really exemplifies what we're presenting to you in the bill you're going to hear about how we can better coordinate care for people with disabilities. Right now, we are spending way too much money. This hospital visit and additional bill with the dentist was almost $30,000, 25 of which was paid by Medicaid. We can't afford that. We have to think differently about how we coordinate care for these emergent situations for people with disabilities. And I know I've talked to many of you, especially Senator Abeler has heard me over the years provide examples of this with the data. But I believe that if we can step back and coordinate different models that we are presenting, we will have the opportunity to think differently and take action differently for how we treat our adults with disabilities that have both medical as well as traditional disability issues that can be handled in a more effective way. So with that, I'll pause. Do you have any questions, or should we go on to the next person?
Thank you, Mr. Clauser. Any member questions for this testifier? Okay. Ms. Box, please introduce yourself for the committee. Welcome, and you may begin your testimony.
Madam Chair, members of the committee, thank you for having us today. I'm Danielle Fox. I'm the Executive Director, CEO of Mount Olivet Rolling Acres. MORA, as it's called, is a nonprofit organization that primarily supports support to Medicaid services for seniors and people with disabilities. We support 4,500 Minnesotans each year with 450 plus staff. And we do that with 32 residential homes, a pretty large case management team, as well as a crisis service that we coordinate for the 7-county metro. I was also, prior to coming to MORA, part of a county government entity where I was their Health and Human Services Director and oversaw about $100 million in waivered funds. So what I learned from my experience in government and then as a service provider is really that there is this large network, this huge ecosystem that we are using to support our vulnerable Minnesotans with disabilities and those in need of senior care. And we all know sort of a piece of the pie. So when it comes to service delivery, we know pieces from social services, from a local dentist, primary and acute care provider, but no one has that full picture. In turn, we each see pieces of that financial picture as well through Medicaid waivers, straight Medicaid, and Medicare services. Having those pieces does not allow us to make educated decisions about what supports a person or a population best, or in spending if we're doing that as efficiently as possible. So this demonstration project coordinates the pieces. It looks at the true data as a whole. It looks to gain insights and ultimately create mechanisms for cost savings, and even better, it provides better care by rewarding positive outcomes. This demonstration project is driven by providers who specialize in that service delivery and is a value-based model that incentivizes the results that matter most to a person. So we appreciate the committee hearing this bill and hope that we can make some meaningful reform to disability services in Minnesota.
Thank you so much, Ms. Fox. And I'm so sorry, I caught your first name, Scott. I did not catch your last name, and it's not on the list. So if you just,
I'm sorry.
welcome to the committee, please introduce yourself, and you may begin your testimony.
Thank you, Madam Chairperson and members of the committee. My name's Scott Hinchy, and not much more to add other than what George and Danielle so eloquently said about the bill, but just that it allows for a demonstration project that, like Danielle said, that coordinates care across Medicaid and Medicare. So really looking at the full spectrum of services that support people with disabilities and mental health conditions in our state. And I think in order to make best decisions about how our system should evolve and reform to support people, we need to not just look at supports in the community or just look at costs in the emergency department. We need to look at the whole picture, and that's what this bill allows for, is a demonstration project to create insights to apply to the system reform moving forward. So thank you very much.
Thank you, Mr. Hinchy. Member questions, Senator Abeler.
Well, thank you, and welcome back, George, and your crew there. It's we've been trying to get this off the ground for how long?
About 5 years.
Yeah, 5 years.
Mr. Clauser.
So,
Senator Abeler.
Senator Hoffman, so apparently to save money, we have to spend money you're not going to have. And so I just don't understand. I don't understand, Madam Chair and Mr. Chair, and to the people, why we have to fuss about trying to get these things off the ground. I don't know why it's not part of the governor's budget. I don't know why this coordination, which everybody says saves money, with the community care hub, with everything else, and all these programs that are in the fee-for-service world. Here we sit again. And, I mean, I don't know who the governor is, Madam Chair and Mr. Chair, and to the people. But they've assembled an array of programming that will actually ultimately increase costs and cause more people to go. We inadvertently apparently adopted one of his proposals, one of their proposals, I guess it's an indefinite to them, that's the governor, to undo foster care, which is now going to really interfere with the care of 2,500 people. And I'm just frustrated as can be about this. I think this idea has extreme merit. It's like the PACE program, where we're going to start doing things that serve people better and save money, or we're going to keep spending $30,000 for something that could have been avoided altogether. So apparently I'm frustrated. I don't mean to act angry or whatever, but this budget spends how much? $40 billion or something is it that much now? It's close, isn't it? Every 2 years. And nobody's able to serve people well on the money that we have. So keep pushing. I hope we can find a way to pull some of this off. And there should be some way to do like a little cash flow thing. Like if you don't have to pay that, like you promise to pay the $2 million in 4 years if it doesn't work. That might, a contingent appropriation, Mr. Chair, might be the answer to get this. So you promise to pay in year 4. If the money doesn't show up by then, get the 4-year budget window, show the savings and actually make money. Maybe we're on to something like that. So Kyle want to work on some contingent appropriation language, and Mr. Monahan will go like, what on earth are you talking about? So anyway, we pass up too many opportunities. I'll quit talking. Thank you.
Madam Chair.
Thank you, Senator Abeler. Senator Hoffman.
Dynamic scoring was used on the seatbelt law and one other one, and I think you said it the other day, Madam Chair. And to the senator, for a good senator from Anoka's point, we know that, like the hub, when Josh Bergen, he's up here, and we know it's going to say, we know that, but we can't score that. And this is really frustrating. We know this is going to save that. So what do we need to do that? I mean, what did they do on the smoking cessation one? That would, Kathy Sharon, I think, was the other one where they used dynamic scoring. So it's been used, Madam Chair. Why can't we do it here, right? That's a question for all of us. That's a question we should be asking. Why can't we? Where's John Marty? Get him here in front of this committee. I want to ask him that question. I'm kidding. And tell him he still owes us $178 million from 2 years ago. So.
Thank you, Senator Hoffman.
Thank you, Madam Chair.
Senate File 2876 is laid over for possible inclusion. Thank you all so much for coming to committee.
Thank you, guys. Thank you, Madam Chair and members.
Senator Hoffman, Senate File 2934. And we were only supposed to finish this bill by 5 p.m., so we're really close.
Are we?
No.
Oh my God, David. Well, you guys put me off. You had Senator Fateh. He jumped in front of everybody, and then Senator Mohamed got to bump me off, and so I'm feeling like the lost.
Senator Mohamed.
Mr. Chair, I just think that the chair should be presenting his bills last.
Yeah. Well, in this case, then what am I doing? Thank you,
Senator Hoffman to the decorum. No. Okay, so Senator Hoffman, Senate File 2934 is before the committee.
Yep.
We have Kara Fateh and Lisa Timian who are here. If they could come to the testifying table.
I think we're good. What we're going to do is this bill, there's some movement in the House. Sean Burke, there's going to be a commitment from Sean Burke, who's, of course, a lawyer who forgets more in a day than a lot of us will when it comes, and working with MDH and I think the long-term care imperative on this one. The House is doing something tomorrow on this. I just want to get this laid over so we can keep the conversation going, Madam Chair. And then, did I say the House? I meant the other body. And with that, I've already talked to the Department of Health. They're going to be working with that, and I talked to Sean Burke, and they're all going to be working. So that's it's our work, folks. It's what we're doing. So, and it's a conversation that we had last session regarding the statute 144G enacted in 2019. I wonder who was the chair of this committee back in 2019 on that one, but we're still defining this. It's great stuff, Jim. So yeah, Madam Chair.
Thank you. Well, Senator Hoffman, I have one thing I want to add to your bill. Maybe it doesn't come this year, but I had some of the work I've been doing with AI.
Yeah.
I had a person from Silicon Valley who used to work at a big tech company who is now kind of whistleblowing on some of the things they're doing, brought up the use of medical restraints or chemical restraints and said that in the not too distant future, she could see a world of digital restraints.
Really?
Mm-hmm. And so had wanted to just provide that as insight, and it might be something worth looking at as a preemptive piece before we arrive in a horrifying place and have to go back and prohibit or regulate it.
Maybe Lisa
Senator
Timian, maybe the Department of Health, is they're looking at this with Sean, if that's something they could, go, and investigate that. Is she shaking her head back there?
Unclear, Mr. Chair. No, smiling.
Oh, okay, then that's a good sign.
Okay.
So with that, I just want to lay this over and keep the conversation going.
Thank you. Senate File 2934 is laid over for possible inclusion in omnibus bill.
Thank you, Madam Chair and members. And now we go to Senator Boldon, who's going to be Senator Wickland instead.
Senator Wickland.
It's all yours. Thank you. Thank you, Senator.
Nope. Sure. Senate File Senator Wickland moves Senate File 2894 before the committee. Senator Wickland.
Yes, thank you. Thank you, Madam Chair. Senate File 2894 is a bill that deals with Supplemental Nursing Services Agency updates. This proposal corrects or does several things. So this proposal corrects a drafting error from the 2024 session regarding the frequency of MDH surveys of supplemental nursing services agencies. Secondly, its original intent was to require surveys every 2 years. This proposal restores the intended biennial schedule rather than the current semi-annual requirement. The bill also clarifies the definition of ownership interest for background study purposes. Currently, SNSAs must submit background studies for any owner, which can include dozens of individuals with very small ownership shares. This change defines ownership as an individual or legal entity with at least 5% equity, reducing unnecessary burden while maintaining oversight. SNSA providers, including publicly owned agencies, support this clarification, which helps reduce cost and complexity. MDH will continue engaging regularly with provider associations, consumer advocates, and other stakeholders to ensure transparency and support implementation. And this is a Department of Health bill, and if there are questions, I believe they are still here to answer them. Thank you.
Thank you. Members, any questions? Lisa Timian, we're good? You don't need to, she's shaking her head. All right. What do you want to do with this one, Melissa? Are we going to lay this one over, or are we going to the floor?
I think it's to be laid over, or
yeah, we can lay it over.
Policy bills.
All right, Senate File 2894 will be laid over. Thank you very much. And next is Senate File 2893, Senator Mann. Senator Wickman.
Thank you, Mr. Chair. Senate File 2893 is the Department of Health Case Mix Review Policy Proposal. This proposal addresses changes required due to the federal shift from the old RUG 4 payment system to the updated patient-driven payment model for Medicare nursing facility stays. Minnesota must update its Medicaid case mix system to align with these changes, as CMS will no longer support RUG 4 after October 1st, 2025. The proposal includes statutory adjustments to ensure accurate reimbursement for nursing home care and services. Additionally, it mandates that facilities inform residents or their representatives in writing and before therapy begins about the impact of therapy on their case mix classification. These updates aim to enhance transparency and ensure appropriate reimbursement for care providers. This also interacts with DHS and is necessary for them to determine the daily rate the facility charges for the resident's care. And this also comes from the agency. If there are any questions, Lisa Timian is available.
So, any conversation there? Do you want to, does Lisa or Autumn need to say anything?
I don't.
Nope. You want to, this one also lay it over to the work that you're doing. Thank you for doing this, Madam Chair. I appreciate the work that you're doing on this. So,
Yes, Mr. Chair.
with that, Senate File 2893 will be laid over possible inclusion into the omnibus bill. Thank you very much. Members, we have finally gotten word, is that correct, Senator Maye Quade? Do we know where Senate File 2640 is got to go as amended?
Yes, Mr. Chair, I would move that Senate File 2640 be recommended to pass and sent to the Committee on State and Local Government.
As amended,
As
correct?
amended, yes.
Awesome. Everybody got that? Any questions? Nope. All in favor say aye.
Aye.
Opposed, same sign. It's on its way. So, members, next Wednesday, please, we're going to do the policy omnibus bill. We actually, our advocacy as a committee got the world in the corner office, so to speak, to understand the difference that we do policy versus budget. So we're going to have our own policy omnibus bill, and then we will possibly, whatever's being introduced on the floor tomorrow, and unless somebody here has or has not something, we'll do that. So does that make sense for everybody? And then the week after next, then we'll start working on our budget omnibus, now that we will get targets by Friday, I assume.
You're going to mark up the policy omnibus?
Next Wednesday.
Wednesday. Thank you.
Yeah, Wednesday, Jim. So.
Thank you.
And then the House is ready for us to send it over to them, so we're good.
Good plan.
There's some good stuff in there, and I'm glad we did that. So with that, members, any other questions, comments? We are adjourned. Thank you for staying here.